2, 1. Please start, ma'am. We are live.
Namaskar and a very good evening to one and all. I welcome you all for the 2-day academic feast on updates in GI oncology. And with immense pleasure, I would like to invite Dr. Srinivas, who is consultant medical oncologist, Bharat Hospital and Institute of Oncology, Mysore, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Thank you so much for that warm introduction. Good evening all. Good evening my friends, my colleagues, my senior faculty members. Today, that being a day one, we are proceeding with sessions on hepatobiliary and pancreatic sessions. Day one, day two will be mainly on the highlights on the recent advances and the recent abstracts which are presented in recent ASCO Gastric Symposium. I thank my academic partners at the outset for this wonderful contribution, without whom this meeting wouldn't be achieved. Without much ado, I would like to start with Dr. Vinay Muttagi. He's a radiation oncologist at HCG Bharat Hospital, Mysuru, to present the first paper. Dr. Vinay.
Sir, good evening.
Hi, Dr. Vinay.
Hi, good evening. Sure, thank you.
Session sponsored by Bayers. Dr. Vinay, over to you.
Is my screen seen, sir?
Yes, sir. It's visible. Can you please make a full screen?
Yeah, I'll put it to the slideshow now. Visible?
Yes, sir. It's visible.
Yeah. Thank you. Thank you, Dr. Srinivas, for this introduction, and thank you for bringing me on board today. I'm really happy to present this path-breaking study, phase 3 study of sorafenib versus SBRT, followed by sorafenib in hepatocellular carcinoma. We all know that hepatocellular carcinoma, when it comes to treatment strategies, those who are not suitable for surgery, they have a huge gamut of options when it comes to like ablation, TACE, and sorafenib. And it has been already seen that sorafenib improves median overall survival from 7.9 to 10.7 months. And the benefit of this is dropped to 6.7 to 8.9 months when we have microvascular invasions, which is seen in most commonly seen in hepatocellular carcinoma, usually portal vein thrombosis or portal invasions. Integrating radiation strategies in hepatocellular carcinoma management has been a key question over past decades, including those patients who have microvascular invasions. This RTOG 1112 was designed to evaluate the role of SBRT plus systemic therapy in hepatocellular carcinoma in a phase 3 model of in an RCT.
Vinay, sorry to bother you. Can you just your on your video?
Oh, sorry, sir. Just a minute. So it's seen now.
Yes, sir.
Yeah. So this RTOG 1112 was designed to evaluate the role of SBRT plus systemic therapy, that is sorafenib, in hepatocellular carcinoma in a phase 3 manner. The hypothesis of the study was to use stereotactic body radiotherapy, some sort of local treatment along with sorafenib, just to see if it improves the overall survival compared to that of sorafenib alone. Secondary endpoints being usually the progression-free survival, time to progression, and the toxicity and the quality of life for those patients who used SBRT as a modality of treatment. Eligibility for this study was locally advanced hepatocellular carcinoma who are not suitable for surgery, post resection with like recurrent lesions, post RFA and post TACE, with child folk being A, platelet levels being more than 60,000, BCLC stage B or C, less than 5 hepatocellular foci, or sum of all the lesions being less than 20 centimeters, with less than 3 extrahepatic metastatic lesions in hepatocellular carcinoma of any degree of vascular invasion being included in the study. Microvascular invasion, hepatitis B versus C, or other North American or non-North American sites, and hepatocellular HCC volume or liver volume being less than 10%, 10 to 40%, more than 40% was stratified, and all of them being evaluated in a multivariate analysis. Randomization was sorafenib versus SBRT plus sorafenib. Sorafenib standard dosage being 400 milligram twice daily, and SBRT of 27.5 to 50 gray in 5 fractions. And usually most of the patients in the trial have received 35 gray in 5 fractions. Unfortunately, the trial closed its accrual prior to the event just because of the standard of care in hepatocellular carcinoma changed from sorafenib to that of immunotherapy as per our IMBRAVE 150 study, saying that atezolizumab with bevacizumab being the standard of care compared to that of the sorafenib, and which has shown better overall survival when compared to sorafenib alone. In that case, the trial closed for its accrual at the early with a sample size of 193. With that, they had maintained the median overall survival of 10.5 to 14.5 months, with the hazard ratio being 7.74. The usual patient characteristics in both the arms were usually maintained, with the median age being 66 years, with some of the diameter of hepatocellular lesions, the target lesions being 7.8 centimeters, the median one ranging from 1 to 19 centimeters, with volume of 180 cc. When we reviewed the protocol, in sorafenib arm, 3 of the patients did not receive sorafenib, and 21% of these patients in sorafenib arm post sorafenib treatment went for SBRT again after discontinuation of sorafenib. Whereas in SBRT and sorafenib arm, 12 patients received SBRT, but they did not receive sorafenib. So SBRT, but they did not receive the chemotherapy. Apart from that, 94% of the patients received SBRT as it was planned. And among them, 1% did not, 4 patients did not complete the planned SBRT. One was progression, and 3 had adverse events. The median dose delivered being 35 gray in 5 fractions, as we have seen that the dose has ranged from 27 to 50 gray almost. And most of the patients has received 35 gray in 5 fractions, which is being the standard of care in when it comes to SBRT, especially in case of liver lesions. The median duration, when we pooled analysis of this statistical analysis showed that the median duration in sorafenib arm being 2.7 months versus 5.1 month in SBRT and sorafenib. The median daily dosage was 500 milligram versus in SBRT it was 371 milligram. Delays in the treatment were almost approximately more when in SBRT plus sorafenib arm compared to that of the sorafenib alone. When we look into the Kaplan-Meier survival curves, it clearly shows that the median overall survival was much better in SBRT and sorafenib arm. You can see the curves being separated, still separated at the end of the analysis, which was almost like 15.8 months versus 12.3 months only in sorafenib versus sorafenib plus SBRT. Overall survival with multivariate analysis with all the events being it from the clinical staging to that of the macrovascular involvement, it shows that a good significant p-value in SBRT plus sorafenib arm versus that of sorafenib alone. This has been equally reflected in progression-free survival and time for progression, that SBRT and sorafenib has a much better progression-free survival compared to that of sorafenib alone, which is like 9.2 months versus 5.5 months. The same was time to progression in case of SBRT plus sorafenib versus sorafenib alone. When we looked into the adverse events, adding SBRT to sorafenib alone has shown no different in adverse events, and the most commonly witnessed adverse event when we use SBRT, when we are using SBRT, is liver failure. Most of the time, especially when all these patients of hepatocellular carcinomas do come with added cirrhosis with that compromised liver status, we usually end up with liver failures, and most of these things, adverse events, have not been reported even in SBRT plus sorafenib arm compared to that of the sorafenib arms. You can see this hepatic failure being almost like 1% in SBRT plus sorafenib versus that of the two, like this number of cases being 1 or 2, it almost like equal in both the arms. The best thing about the trial is they have looked into the quality of life too, using a fact questionnaire in SBRT versus sorafenib. Unfortunately, most of the patients have not filled it. Though for those patients who have filled the questionnaire, they have seen that quality of life was much better in SBRT plus sorafenib arm versus sorafenib alone. Most of the patients, I mean, like you can see the pie, I'll put up the pie chart in the last, which clearly shows that quality of life was much better for those patients who received SBRT with sorafenib versus sorafenib alone. This is the fact questionnaire that which they have used, which is being labeled as fact HEP, which has a total score of 45 items, with one which is completely for that of the general category, and additional concerns which are very particular for that of the hepatocellular carcinomas, totally adding to a score of around 0 to 72, no, 0 to 108, including everything: physical well-being, social well-being, emotional well-being, functional well-being, all these put together with additional concerns which are very specific for that of the hepatocellular carcinomas. So I have told that the QAL consider when they have seen that from the baseline at the 6-month data and complete after 6 months, when they have seen the quality of life, which is like much better in SBRT plus sorafenib arm compared to that of sorafenib alone. This is the pie chart which I was talking about. You can see clearly that sorafenib, this the part which is labeled in green is for that of improved quality of life in SBRT plus sorafenib. You can see it is almost amounting to 35% versus 10% which is seen in sorafenib alone. To conclude, in patients with advanced hepatocellular carcinoma compared to sorafenib, SBRT prior to sorafenib has improved overall survival, progression-free survival, and time to progression, with less concerning increase in adverse events. A strong suggestion of quality of life at 6 months was observed in addition of SBRT to that of the sorafenib alone. SBRT is a standard option for patients with locally advanced hepatocellular carcinoma, especially with those with microvascular animation. Probably the trial closing prior to its this thing would clearly put us a path for future studies, saying that as we all know that immunotherapy being the standard first line treatment now for hepatocellular carcinomas which are unresectable in the place of sorafenib. In that way, probably adding SBRT to immunotherapy might give us a better picture, and that gives us a good path for future research and studies. Thank you. I'm open for questions. Thank you, sir.
Dr. Vinay, that was an excellent presentation. Thanks for that wonderful presentation. I also want you to tell that audience that we have started SBRT in our own center. And this is something which is very much doable. Today, we can proudly say that this is something which we can do it in our center, isn't it?
Yeah,
so
definitely.
Whenever we talk about the abstracts, the very first question what comes to our mind is it something which can be done in our hospital?
Definitely.
Can we do something? Is it practically possible? Is it something which is doable in our center? So
definitely. Any LINAC, any linear accelerator which is capable of having micro MLCs is capable of doing SBRT when we have 4 DCTs with gating mechanisms, and with the LINAC which is equally capable of doing other regular techniques like IMRT and VMAT. So with that, then probably we'll be able to definitely deliver stereotactic body radiotherapies. With the biggest challenge what we face when it comes to SBRT to liver is tracking the liver and tracking the target, because liver is one thing which moves with respiration. In that way, probably with a good respiratory gating, we'll definitely be able to deliver SBRT with a precise dose delivery or precise dosing.
So Vinay, is there any patient selection you need to choose? Like say, which are the patients? Like, yes, this is the patient, I can definitely take him for SBRT followed by sorafenib. Is it something like that?
What I feel, sir, with my clinical practice, what I feel is as the trial has picked up nicely, all those patients who are not suitable for surgery, most of the times we choose patients who are not suitable for surgery. Probably we should come up with something like when it comes to standard, those patients who are suitable for surgery also can be picked up. Just to cut it short and to be precise to this presentation, I would say that any patient having a good liver reservoir with Child-Fook criteria, like scoring being A, and with any like hepatic lesions which are less than 20 centimeters, or some like less than 5 lesions, 5 hepatic targets, probably that should be a good deal to go ahead with SBRT.
That's nice. Yeah, thanks for that question. Thanks for that answer. Next, I think if there any question from the audience, we will take it up. They can even text us. They can raise a question so that Dr. Vinay will be happily answering any of those who need to get this one. Anything. Then we will move on to next topic. I think Dr. Basant Mahadevappa is held some emergency. He is going to talk after Dr. Aparna's presentation. If Aparna is ready, I think I'll ask Dr. Aparna to present her abstract.
Yeah, so shall I start, sir?
Please go ahead.
Yeah, thanks a lot, Dr. Srinivas, for this great opportunity. And the topics are also really very interesting. And I thank the organizers for this great opportunity. This my topic is tislelizumab versus sorafenib as the first line treatment for unresectable HCC. The impact on health-related quality of life. The Rationale 301 study. Next slide, please. Yashika, next slide, please. The slides are not moving.
Support team, Ekta ji.
Yashika, please. Next slide, please.
Next slide. So as we all know that hepatocellular carcinoma, the last 15 years have been very promising. Though it is traditionally considered a chemo-refractory tumor, we are having many targeted therapy, the tyrosine kinase inhibitors as well as immunotherapy. Next slide, please. So we know the global burden of HCC, hepatocellular carcinoma is among the top 10 killers, both globally as well as in our India as per the Globocan data. And most of the times the diagnosis is in advanced stages, and the treatment definitely affects the quality of life of patients, both physical as well as psychological and spiritual quality of life domains are affected. So this is a very unique concept, this study. It has looked very meticulously into the quality of life data of patients. And I'm really excited to be presenting this abstract. So the objective of this study was to evaluate the impact of tislelizumab monotherapy on patients' health-related quality of life and the HCC-related symptoms. Next slide, please. So we all know that PD-1 inhibition is an important strategy for treating unresectable HCC patients. And we have these other PD-1 monoclonal antibodies, nivolumab and pembrolizumab, but both of them are not approved in first line as monotherapy. So we also know that PD-L1 positive patients have an aggressive course and very poor response to treatment. And so the monoclonal antibodies against PD-1 is an important strategy for HCC control. Next slide, please. So let's understand what this tislelizumab is and how it works. So it is another PD-1 inhibitor, just like nivolumab and pembrolizumab, but it is a humanized IgG4, and it has a high affinity and binding specificity to PD-1, and it dissociates slowly from PD-1 compared to nivolumab and pembrolizumab. So it binds to the PD-1 with more higher specificity. Next slide, please. And another interesting thing is that it is genetically engineered to have more binding to the FC, to bind less to the FC receptor of the macrophages, so that they are not eliminated from the body. So binding to the FC receptor of macrophages is an important strategy. It's an important mechanism by the tumor to escape from the effect of PD-1 antibodies. So before the tumor gets an opportunity to bind to PD-1, it is eliminated by the macrophages. So tislelizumab is specifically designed to combat this mechanism of resistance so that it can bind to the tumor with higher specificity and have more tumor cell kill. Next slide, please. So, this is a phase 3 randomized trial where tislelizumab 200 mg every 3 weekly was compared with sorafenib 400 mg BD, and the patients were randomized in 1:1 fashion. Next slide, please. So the key clinical cycles were cycle 4 and cycle 6, and they were selected to measure the short-term change in quality of life and the long-term change as well. So any difference in the quality of life from baseline to cycle 4 and cycle 6 were analyzed with the quality of life questionnaires. And another important it was a non-inferiority trial when the overall survival was considered, and tislelizumab was non-inferior to sorafenib in terms of overall survival. Next slide, please. So when the patient demographics and patient characteristics were considered, the age was almost same in both the groups, and majority were men. And the ECOG performance status was 0-1, and child score was A, and majority of patients had extrahepatic spread also. So it was quite an advanced stage of HCC that they took, and many of the patients also had liver-directed therapies like TACE. Next slide, please. So the demographics were comparable. So coming to the quality of life scales, when compared to sorafenib, the patients who received tislelizumab, the quality of life didn't deteriorate. So just imagine your own patients where we have given sorafenib. With every month on month, patients come with a lot of complaints like fatigue and nausea, vomiting, hand-foot syndrome, and many patients cannot tolerate sorafenib. So considering the circumstances with sorafenib, tislelizumab is a very good addition to the armamentarium, where overall survival is almost, it is non-inferior to sorafenib. And when quality of life scales were considered, quality of life was maintained with sorafenib, both in the short term as well as in the long term. Next slide, please. So when we come to the symptoms of HCC, especially pain and nausea, fatigue. So this study has considered multiple symptoms of HCC, and the data said that at cycle 4, which is short term, as well as cycle 6, the quality of life and the pain scores were better in tislelizumab arm compared to sorafenib. Next slide, please. So the pain scale with the visual analog score was done at both cycle 4 and cycle 6, and it worsened in the sorafenib arm, whereas it was maintained in the tislelizumab arm. So for a patient who is having an advanced disease, we are really worried about the quality of life and pain management. So it is really interesting that tislelizumab is faring superior to sorafenib when it comes to quality of life. Next slide, please. So the next parameter that they have considered is the deterioration of the quality of life, the physical functioning and fatigue. So in all the parameters, tislelizumab scored over sorafenib, and they have considered fatigue and pain and the physical functioning, and it was all preserved with tislelizumab arm. Next slide, please. So to conclude, Rationale 301 study met the primary endpoint and the key secondary endpoints of overall response rates and safety. So overall response rate with tislelizumab was 14%, whereas it was 5% with sorafenib. And coming to the duration of response, the duration of response was nearly 36 months with tislelizumab, whereas it was around 11 months with sorafenib. So tislelizumab monotherapy is as a first-line treatment for patients with HCC. It was associated with more favorable quality of life outcomes compared to sorafenib. So compared to patients receiving sorafenib, tislelizumab had less worsening of general health status, physical functioning, fatigue, and HCC symptom index. So these results, along with the effects of on overall survival, response rates, and favorable safety profile, that supports the benefit of tislelizumab as a potential first-line treatment option for untreated HCC. So coming to the side effects of tislelizumab, mainly the immune-related adverse events happened more than grade 3 happened in nearly 5 to 10% of patients, and it was mainly hepatitis and hypothyroidism. So I think overall we have a new champ immune checkpoint inhibitor with us. So only time will tell as to how it will fare in the real world, but the data looks very promising. Thank you.
Thank you, Dr. Aparna. That was an excellent presentation. So tomorrow, if the cost is not any consideration, and if the drug is available in your pharmacy tomorrow, would you like to start tislelizumab in your patient?
Yes, sir, definitely. So what happens with sorafenib, even with lenvatinib, we have a set of patients who will not tolerate it, and they'll come with very bad hand-foot syndrome, and we feel guilty that we actually worsen the quality of life. So I think if cost is not an issue, and as we know, in the first line setting in HCC, there is no monotherapy. Either we have to give Atizo with bevacizumab or durvalumab with tremelimumab. So sometimes we don't want to give everything, like we don't want to give a combination. Single agents always score over the others.
So what's the beauty of these newer evolving things are, like there are a lot of options. For example, as you said, if the patient X tomorrow, he is a very frail, very elderly patient, at least we do have the options of giving these patient-friendly drugs. Otherwise, as you rightly said, it's very difficult to see them with a grade 3, grade 4 toxicity, where we are helpless to say that this is what we can do today. Otherwise, it's a best supportive care. So the beauty is we have a lot of options, like whether if the patient can afford Atizo with Bev. Now there is one more trial, another trial, Himalaya trial, the durvalumab with tremelimumab. Now we have tislelizumab. So there are a variety of options which was never there. We never imagined in metastatic HCC these things will evolve. So thanks to the science, thanks to technology, now we have a lot of options to at least offer them, isn't it? So that's a very nice presentation. Thank you so much for joining us, Dr. Aparna. If any doubts, anybody, let us know. Please, you can even text in a chat box so that we'll be happy to answer it. Without further delay, then I think I can call upon Dr. Basant Mahadevappa. He's a transplant consultant in HCG Bangalore. He's my very good friend and senior. Dr. Basant, are you there?
Yeah, I'm here. You're able to hear me?
Hi, Dr. Basant. Thanks for joining us. Dr. Basant, in spite of his busy schedule, and there was an emergency in the family, even that he could manage to join us. Thanks for that, Dr. Basant.
You're welcome.
I welcome you to this wonderful meeting. Without much delay, I request you to start the presentation.
Yeah, I'm not able to share the slide. Just a minute. Okay, I think.
Technical
Yeah.
team.
No, it's there. Do you guys see it?
Yes, very much.
Yes, sir, it's visible.
Okay, wonderful. Good evening, everybody. I mean, it's wonderful to be here amongst all of you, and thank you, Srinivas, and thank you, everyone out there. Sorry for the last minute joining, and sorry, Dr. Aparna, you had to do it before my presentation. So what I'm going to talk is it's a very interesting talk. I mean, it's an interesting study that has been published from Zhuangzhou, China. It is about adjuvant transarterial chemoembolization with sorafenib for hepatocellular carcinoma patients with portal vein tumor thrombus after surgery. It's a phase 3 multicenter randomized controlled trial. It's very close to me because I started doing this procedure much before it was conceptualized, because I do interventions as well, being a surgeon. So the background, what brought us to this study, I mean, probably what made the scientists do this research is that, a lot of these patients with hepatocellular carcinomas present with portal vein tumor thrombus. But these patients are otherwise ECOG status 1 and otherwise healthy. And we always felt that these patients would benefit from not just adjuvant treatment because they have a tumor thrombus not just palliative treatment because they have portal vein tumor thrombus, but I think something more can be done. What happens when there is a portal vein tumor thrombus and we deem them to be advanced stage because of the vascular involvement? The survival rate drops down substantially if we do not take some radical steps, especially in very well selected patients. Hepatocellular carcinoma, we know that it's the 6th commonly diagnosed cancer worldwide, and once the stage progresses, the mortality is very high. More than 50% of these patients present with portal vein tumor thrombus. Yeah, this we can say, especially in the eastern part of the world as against the western part. Surgery is recommended for very selected portal vein tumor thrombus patients to achieve better survival. We are studying this because we know that the recurrence rates after surgery for these patients are very high. So the tyrosine kinase inhibitors plus transarterial chemoembolization as a combination adjuvant therapy showed a prolonged survival in recent retrospective studies. So what we do right now including my practice, is after surgery for patients with portal vein tumor thrombus who are very well selected, post-surgery, post-recovery, we do transarterial chemoembolization with adrimycin and DC beads, followed by treatment with tyrosine kinase inhibitors. So the purpose was to explore the efficacy and safety of sorafenib plus TACE, that is SOR-TACE, as postoperative adjuvant therapy for HCC patients with portal vein tumor thrombus. The study design was like the patient with resectable advanced hepatocellular carcinoma, advanced in the sense that the ones with portal vein tumor thrombus with adjuvant sorafenib were reported to have a 2-year recurrence-free survival rate of around 20%, whereas SOR-TACE treatment is expected to increase the 2-year recurrence-free survival rate to 38%. The sample size in the study was 158 patients, and the age group consisted between 18 to 75 without any previous treatment. There has to be presence of portal vein tumor thrombus. Resectability should be assessed. ECOG status chosen was only 1. Child Cook class, again A. Expected life expectancy was at least more than 3 months. Satisfactory blood parameters. And the portal vein tumor thrombus grade 1, 2 versus 3 were assessed, and they were randomized into two arms. One was TACE plus sorafenib. TACE starts 1 day after sorafenib, and sorafenib alone group. Primary study endpoint was recurrence-free survival was noted. Secondary study endpoint was overall survival, safety of the medication, and the quality of life. So the main inclusion criteria and the exclusion criteria: age was 18 to 75 years, adults, HCC patients without any previous treatment, presence of portal vein tumor thrombus, resectability with no extrahepatic metastasis, no more than 3 disseminated nodules, and the portal vein tumor thrombus grade 1 to 2, and no serious coexisting systemic illnesses, ECOG status 1. liver function shows that these patients belong to childhood grade A. Expected life expectancy was at least 3 months, and blood parameters were normal. The exclusion criteria was infiltrative hepatic lesions with tumor invasion that would go into either IVC or superior mesenteric vein. And the other exclusion was where R0 resection was not achieved according to the postoperative pathological evaluation. Medical history of hepatic decompensation such as hepatic encephalopathy, refractory ascites, presence of contraindications for TACE such as shunts and hepatofugal flow. So the 213 patients were assessed for eligibility and 55 were excluded. 47 did not meet eligibility criteria, 5 withdrew consent and 3 excluded for other reasons. Out of the 158, 79 were assigned for sorafenib plus TACE and 79 were sorafenib alone. 79 including the intention to treat patient. So the one patients were lost in both arms, 54 discontinued treatment in arm, and 68. Most of them were the ones who discontinued was for side effects. And there were 30 recurrences in sorafenib SOR-TACE group and 48 recurrences in sorafenib alone group. And 22 adverse events were noted in SOR-TACE and 19 adverse events in sorafenib alone group. So what were the baseline characteristics? It was, most of these patients were hepatitis B patients. To look at that, the males were again more in both the arms. AFP less than 400 and more than 400 were almost comparable. The cirrhosis, no cirrhosis patients in both arms were equal, and cirrhosis patients were also equal. Size less than 5 centimeter in sorafenib alone group were 18 and SOR-TACE group were 25, and more than 5 centimeter tumor size 61 patients among 79 in sorafenib alone group and 54 in SOR-TACE group. Macroscopic portal vein invasion were seen in 49 out of 79 patients in sorafenib, 53 in SOR-TACE group, and grade 3 were 30 patients were noted among 79 and 26 among SOR-TACE group. So the recurrence-free survival were noted to be in SOR-TACE group to be 16.8 months as against 12.6 months in sorafenib alone group. The recurrence-free survival was also better in the SOR-TACE group, and overall survival also in the SOR-TACE group was 30.4 months as against 22.5 months in sorafenib alone group. So the subgroup analysis, if we look at it, most of the analysis in the recurrence-free and the overall survival favored more towards SOR-TACE group as against sorafenib group, except when the number of tumors, if they were single, the sorafenib arm did fare well. That is probably because the nature of the disease. And again, main tumor size less than 5 centimeter, they again favor the sorafenib alone group in both recurrence-free as well as overall survival subgroups. So the adverse events were very similar in both the arms. The hand-foot syndrome, hand-foot skin reactions were the commonest, and it was seen in both the arms because it had hardly anything to do with the chemoembolization. The other symptoms like diarrhea, hypertension, alopecia, nausea, vomiting, all of them were not significantly different in both the arms. So in conclusion, this study gave that the combination of sorafenib plus transarterial chemoembolization in an adjuvant setting for hepatocellular carcinoma patients with portal vein tumor thrombus resulted in longer both recurrence-free survival and overall survival compared to sorafenib alone. And adjuvant local treatment in the form of transarterial chemoembolization and tyrosine kinase inhibitor combination therapy provide an effective way for control of advanced hepatocellular after surgery. So before I conclude, I also want to say that we also at our center perform not just resections, we also perform microwave ablations in these patients, elderly with some comorbidities, not really want to take higher surgical risk. So in these patients, we do combine the modality of microwave ablation or ablative therapies with, again, transarterial chemoembolization and subject them for TKIs after the procedure. So thank you very much, and thank you very much for the patient listening.
That was an excellent presentation, Dr. Basant. Earlier, portal vein thrombosis was a relative contraindication or a contraindication as such for TACE. So how that changed, or what is your opinion on that?
See, the reason why TACE was not performed for portal vein tumor thrombus was because when you embolize the artery, and already the portal vein flow to that portion of the liver is not there. So it is like, the hepatic reserve for the normal functioning is going to be further dampened, and the chances of hepatic failure after transarterial chemoembolization will be higher is what the thought process was. But we have to realize that these patients, if they have no ascites, the ones with portal vein tumor thrombus, if they don't have any decompensation, and these tumor thrombi the tumor is entering the portal vein from the tumor itself and not actually eating away the portal vein, these patients are good candidates for TACE, because along with treating the tumor, the same chemoembolization material and the chemotherapeutic medication also treats the tumor thrombus along with the arterial supply. And in my practice, because I do both TACE surgery and microablation, I have seen the tumor thrombus shrinking alone with TACE. I mean, for those patients who do not go for surgery.
So that tumor thrombus is essentially a tumor thrombus.
Correct, but there are
cell kill.
No, we have to identify whether it is a tumor thrombus or the portal vein is actually infiltrated by the tumor. The ones which are actually infiltrated by the tumor have bad prognosis. We have to, take them up for surgery or for any procedure with a lot of counseling to the patient, that the chances of recurrence are really high.
So generally, how many sessions of TACE would be required in these patients? Is there any?
No, if we do surgery, then we have to do the TACE as an adjuvant procedure, just like how you give TKI immediately. Yeah. And then we follow them up with, every 3 months scan for a year. And if we see that there is any arterial enhancement at the margins or, there is any more disease, then we can always subject them to more TACE procedures.
So we can repeat the TACE depending on their...
Exactly. Exactly. And more so because once the resection is done and there is a recurrence after a certain period, and if there is a major resection, the liver would already have hypertrophy. So there is no problem in subjecting them for repeated cases.
Great. Yeah. Thanks for answering that. I thank once again Dr. Basant who has given an excellent presentation. Thanks for that, Dr. Basant.
Thank you for the opportunity, Dr. Srinivas.
We'll move to the next session. This session is sponsored by Roche. The next two sessions. First session would be addressed by Dr. Nitin Murthy, who is a consultant medical oncologist at Manipal Hospital, Bangalore, and Dr. Anand Kulkarni for the second session on real-world evidence. First, I will call upon Dr. Nitin Eshes to present his presentation. Over to you, Dr. Nitin Eshes.
Yeah, so thank you to Dr. Srinivas, all the organizers and Roche for giving me this opportunity to present on this very important topic on what is the optimal first line management in advanced or unresectable hepatocellular carcinoma. And really, we have seen how the landscape has changed with atezolizumab and bevacizumab coming into the picture as such. I'm not able to share the screen. Is someone going to share the screen or? All right. So this is my disclaimer. So we know that liver cancer constitutes almost 5% of all cancer diagnosis. Is the 6th most common cancer worldwide with almost 10 lakh new cases. But what is more important to take a note is the fact that it is the 3rd leading cause of global cancer mortality, accounting for almost 8.5% of all cancer deaths. That's why we all know that HCC is an aggressive disease as such. Next slide, please. Next slide. Right. So the previous slide, please. Yeah. What is important to also understand is that it's not just the developed countries, but even in developing regions that we are seeing global incidence of liver cancer, which is growing up with out of almost the 8 lakh odd cases which are occurring per year, more than 75% of cases are occurring in the less developed regions of the world. And we also are seeing that there is a gender predilection with men having a more than 3 times higher risk of developing liver cancer than women as such. Next slide. So the most common is, of course, hepatocellular carcinoma. All the others are less than 10% as such. The majority is HCC, and that is what we are going to be talking about today. Next slide. So the most important risk factor, as we all know, for developing HCC is cirrhosis. Now, cirrhosis can occur due to viral infections such as hepatitis B or hepatitis C. It can occur due to alcohol. Nowadays, we are seeing a very increasing trend of NASH, which is non-alcoholic steatohepatitis, and of course, exposure to toxins such as aflatoxins as such. Now, what this does essentially is puts the liver into a chronic state of necrosis followed by regeneration. This pathologically leads to a stellate cell activation, which when combined with hepatocyte senescence causes cirrhosis, which can progress to HCC as such. What we also need to keep in mind is that about 10 to 20% of HCC does not arise from cirrhosis. Next slide. So what is the scenario in our country as of now? Now, worldwide, we are seeing almost 8 lakh to 9 lakh new cases per year. In India, we are seeing almost 35,000 new cases of liver cancer. And again, one of the leading top 10 causes of cancer causing mortality with almost 35,000 patients who died due to liver cancer. Next slide. Why it is very important is that most of the patients are detected in an advanced stage, which is leading to high mortality rate. The 5-year survival rate is a very poor 2.3%. And we all know that till about 2 years back, the only option that we had was TKIs as such. And of course, with TKI, we had to deal with its own share of side effects and toxicity as such. Now, with the advent of Tecentriq and Avastin as such, we are now starting to see that the whole landscape of the first line treatment of HCC is changing as of now. Next slide. Next slide. Right. So why are we talking about combining IO with an anti-VEGF agent? Now, we had similar studies being done by the other IO agents, but what was the pathophysiological benefit that the combination of IO with the anti-VEGF gave us as such? That is what we will see in the next few slides. Next slide. Right. So we know that there are some anecdotal reports where there has been spontaneous regression of tumors in HCC, which like in RCC, we say could be due to the presence of immune-mediated anti-tumor activity. Many studies have also shown that more than 50% of HCC patients have tumor-infiltrating T cells, and it's the presence of these TILs which has been shown to correlate with a better PFS as such. And like most other tumors, including RCC as such, we know that HCC may evade the immune surveillance by expressing upregulating PD-1, PD-L1, and the other checkpoint inhibitors such as other checkpoint pathways such as CTLA4, TIM3, and LAG3. Next slide. Why the combination of IO plus VEGF is that it acts at multiple steps of both tumor initiation and tumor propagation as such. Now, bevacizumab normalizes the tumor vasculature, which increases T cell infiltration. It also plays a role in decreasing the activity of the immunosuppressive cells, particularly the Tregs as such. And when combined with atezolizumab, which of course promotes the T cell activation and acts as a checkpoint inhibitor, this becomes a lethal synergistic modality to target the cells. Next slide. So we had the landmark IMBRAVE 150. It was a phase 3 trial of first-line atezo plus bev in patients with advanced or unresectable HCC. Next slide. So when we look at the study methodology and the enrollment criteria as such, we can see that they included all patients who had metastatic or unresectable HCC in the first line setting with no prior systemic therapy. Atezolizumab dosed at 1200 milligram 3 weekly with bev at 15 milligram per kg. It was an open label trial with enrollment being done in a 2:1 ratio, with the other comparator arm being sorafenib being dosed at 400 mg BD. They also stratified according to the region, the ECOG PS, presence of macrovascular invasion or extrahepatic spread, and baseline AFP with a cutoff point of less than 400 or more than 400. The co-primary endpoints for this study was the OS and the PFS. Treatment would continue till unacceptable toxicity or loss of benefit as such. Next slide, please.
Technical team.
Yes, sir.
Did he lose his server or something?
Yeah, sir. Nitin sir is joined.
Hello, can you hear me?
Yes, sir.
Nitin,
Yeah.
You are not audible.
Just go back to the previous slide. Slide. The other secondary endpoints that they looked at was, of course, the objective response rates, and also they looked at the RECIST criteria as such. Next slide. The baseline characteristics were well matched across both the groups as such. Majority of patients were in ECOG PS 0, which is slightly different from what we encounter in the real world settings. The study predominantly included a Child-Pugh classification of A5 up to A6 as such, which again may not be the typical sort of patients that we see in a real world setting as such. BCLC-C was the predominant subgroup of the liver hepatic cancer that we see, with almost 82% of them belonging to BCLC-C. About 49% of them were positive for HBV infection, and 21% of them were positive for HCV infection as such. 63% of them, in fact, had extrahepatic spread, and the presence of either hepatic spread or a vascular invasion was present in 77%. So if we can see from the study demographics of the kind of patients that were enrolled, we are seeing that they are pretty much a high-risk patient that was being enrolled in the study. Next slide. So when we look at the PFS endpoint, we see a clear separation of the curves. Now, numerically, you may not be seeing that much of a difference, though statistically, it is a benefit of almost 2.5 months, 6.8 months versus 4.3 months with a hazards of 0.59. But when we talk about immuno, we always say that the gold standard is OS and the tail of the curve. Next slide. So before we go to OS, we need to understand that in the sorafenib arm, almost 26% of them crossed over to receive immunotherapy in the second line setting. And this is something we must keep in mind when we look at the OS curves as well. Next slide. So the benefit clearly present in OS. So the initial analysis showed that the median OS was not reached with the sorafenib arm touching almost 1 year of survival, 13.2 months, a clear benefit in the hazards ratio of 0.58. And what is more remarkable is the tail of the curve. The tail of the curve showing a clear difference, and this is something which we never saw in HCC before, where we saw that the 5-year survival was only about 2 to 3%, but here you know that in those who respond, they are going to have a durable benefit of response. Next slide. The updated OS also confirming the benefit persisting as such, 19.2 months. This was one of the first trials which showed a OS benefit in terms of numbers that crossing 1.5 years versus sorafenib at 13.4. Hazards remaining more or less the same, around 0.65 as such. And again, a clear separation in the tail of the curves that we are seeing. Next slide. Next slide. When we look at subgroup stratification, we can see that this benefit, the previous slide. When we look at the subgroup stratification, we can see that the benefit is present across all subgroups as such. The previous slide, please. Yeah, this one. Yeah, you can see that whether it is BCLC-C or BCLC-C, the benefit was there. The only place where the benefit was probably not there was BCLC stage B, because the confidence intervals are crossing the hazard ratio of 1. But otherwise, be it the performance status, be it the level of AFP as such, and when you look at the high-risk stratification, especially of extrahepatic spread and of presence of vascular invasion, there was a clear benefit for the combination of atezo plus bevacizumab. Next slide. The objective response rate, which was one of the secondary endpoints, and this is what we want in HCC, because we know that patients with impaired liver function start deteriorating rapidly. When we counsel patients, we always say that once the liver is involved, it's very unpredictable and you really can't put a number to the survival, and that is why you want a response and you want a faster response. And this is where again the combination is showing a benefit as compared to sorafenib, almost a doubling of response with 27% response rates as such, a disease control rate of 74%, which was truly remarkable as such. Next slide. The updated duration of response again showed that the median duration of response was 18.1 months. And even when we look at the modified RECIST criteria, there was a clear benefit of almost 4-5 months with 16.3 months as such. Next slide. What was remarkable also is that you had about amongst those who had responders, about 8 to 10% achieved a complete response. Safety wise, no major side effects as such. Any grade side effects were comparable between both the arms. Grade 3, grade 4 adverse effects were again comparable in both arms. Adverse effect leading to withdrawal was slightly higher in the atezo-bev arm, 16% versus 10%, which is again expected, possibly again due to bev-related issues such as hypertension or known side effects which are associated with bev. Next slide. And this is what is characteristic when you're comparing a combination of IO plus anti-VEGF versus a TKI. You can see typically the diarrhea, the hand-foot skin reactions, a decreased appetite are all commonly seen with TKIs, whereas with the IO plus BEV combination, you again see more of possible immune-related adverse events or sometimes anti-VEGF related side effects such as increase in proteinuria, hypertension, which was characteristically more in the atezo-bev arm. Next slide. One concern when we always use bevacizumab, which always makes us little concerned as clinician, is what is the chance of it going to be of bleeding as such? Should I be worried about the varices? What happens if the varices have? What this really shows is that the rate and grade of bleeding amongst comparing different studies as such, even when we look at the reflect trial, which looked at lenvatinib and sorafenib, was not that much. It was about 4% in the reflect trial, and in the IMbrave 150 it was 6% in both arms as such. What we need to understand is that patient selection is the key here. The trial did not include patients who had incompletely treated gastric varices or esophageal varices or those who had high risk of bleeding. So patient selection for this first line of treatment is very important, which again poses a challenge in the clinical setting. Next slide. Next slide, please. Next slide.
Gitika, next slide, please.
Already run my side. Nitin sir, is it visible?
Again, not much difference in the liver functions. We know that IO-related stomatitis can happen, but again, by and large, fairly well manageable, even in the presence of primary liver cancer, more or less toxicity when it comes to the liver. Next slide. Next slide, please. One very important aspect which we always need to keep is what are the patient-related outcomes? What is their quality of life? And in all parameters, the combination of Tecentriq plus Avastin was showing a much better benefit. Time to deterioration was almost a year as compared to just 3 months in the sorafenib arm. Next slide. Next slide, please. Even when we look at different parameters of quality of life, such as physical functioning and role functioning, the median time to deterioration was much longer in the Tecentriq plus Avastin arm as compared to the sorafenib arm, which was typically in few months, whereas there was almost a year of benefit of time to deterioration when you look at the Tecentriq plus Avastin arm. Similar parameters for all other parameters which you look, which can affect a patient's quality of life. The combination therapy with atezolizumab plus bev showing superiority to sorafenib as such. Next slide. Next slide, please. So if we were to look at systemic therapy for HCC in today's era, we clearly are possibly seeing at the previous slide, please. We are possibly seeing that Tecentriq plus Avastin will possibly be the first line choice. In real life practice, that is going to be the main challenge. Cost is a concern in our country, and possibly in such patients who are not affordable for a IO plus TKI combination, we would then go and use lenvatinib alone. And if they progress on the TKI IO plus VEGF combination, you would then sequence with the TKI in the second line. And if they have not used IO in the first line setting, you would possibly use a combination of dual IO therapy in the second line setting. With that, I would like to end my talk. I would like to thank the organizers and Roche again for giving me this opportunity.
Thanks, Dr. Nitin. That was a wonderful presentation. So how do you choose which patient has to go to IO with BEV, which patient you choose, whether the patient should go to TKI? How do you choose in your practice?
I'm not able to hear
Nitin,
you properly,
am I audible?
sir. I'm not sure if there's some issue. Hello.
Are you there?
Yeah, yes, sir. Yes, I can hear you now.
Yeah. So in your practice, how do you choose which patient should go for IO with BEV, which patient should go for TKI at the upfront? What is your practice? How do you do that?
Yeah, so one major thing which influences is the presence of varices, and of course the child score. What we need to understand is in that the trial they very strictly took A5, A6. Sometimes in real world we have tried to give that benefit, stretching it to patients who are B7 as such. But anyone who is beyond that, we wouldn't try to go with this combination because we know that the risk possibly with BEV may be a little bit higher. So I would say the major determinant in choosing would be the child scoring and the presence of varices, and if they are treated or not, between choosing only a TKI versus going with IO plus TKI as such, IO plus anti-VEGF as such.
I think this brings out one very important information also. Before we choose IO with BEV, we should take a gastroenterologist opinion, whether they do an endoscopy, whether the variceal bleed is addressed properly or not. I think this brings very important information to our clinical practice, isn't it?
Sorry, sir. I mean, I lost you again in between.
Before we make a treatment decision.
Yes, sir.
We need to make sure that patient underwent endoscopy, whether the varices is under control or not.
Correct. Yes, definitely. So for all patients, we do a checkup with OGD as such, and again treat the varices. But again, even after treatment of varices, we can't use BEV immediately as such. But whereas if they have already seen a gastroenterologist a few months before and have had treated varices, then we would be more comfortable in choosing the IO plus anti-VEGF combination as such.
Very much. Very true. Any questions from the audience? Yes. Text it in chat box so that happy to answer that. I would like to call upon Dr. Anand V. Kulkarni for the next session on real world evidence of atezolizumab in HCC patients.
Sorry, sir. I'm very sorry. Again, I don't know. There is some problem with the audio.
Can you please allow me to present my slides?
Yeah, sure, sir.
Sorry, I forgot to introduce him. Dr. Anand is a senior consultant, medical oncologist, Department of Hepatology and Liver Transplant, AIG Hospital, Hyderabad. Over to you, sir.
Thank you very much for the kind introduction, sir. Unfortunately, I'm a hepatologist, not an oncologist, sir.
Okay, never mind, sir.
Thanks a lot.
We want to listen to you. What is the real world experience of atezolizumab in your practice?
Thanks a lot for the invitation, Dr. Srinivas. It's an honor to be here. I will just present whatever I know a little bit in front of the oncologist over here. These are disclaimers from the Roche, nothing related to me. This is the outline of the talk, which I will be discussing upon BCLC updates, how to choose a patient, what is the real world scenario, how to downstage a patient to transplant and bridge him to transplant, how many cycles of atezolizumab can be given, assessing the response, predictors of therapy, real world data, and adverse events. So BCLC 2016, we actually, all the hepatologists rely on the BCLC. So for us, it's the major guidelines for us. So at BCLC-C, systemic therapy is the treatment of choice. Till now, the major differences between the older one and the newer one is the survival. It was only 10 months in the previous guidelines, while in the recent guidelines, it has been changed to more than 2 years. So there are several other changes, but the most important thing is the better systemic therapy we have now, and the survival has increased to almost from 10 months to almost more than 2 years. There are several drugs which are in line, and the ones which has hit news is the NEGM article, which was published by Richard Flynn on atezolizumab, and it has been the talk of the town for the past 3 years. We heard about Dr. Nitin how atezolizumab works in HCC. It has good overall survival, better progression-free survival, but the comparison here was sorafenib. And when they assessed the RECIST criteria on RECIST criteria, the response rate, objective response rate, was much better with atezolizumab than sorafenib. Similarly, disease control rate was also better with atezolizumab than sorafenib. Following the approval of atezolizumab, there was a significant increase in the use of atezolizumab worldwide. In fact, this is the US data where they say the use of sorafenib and lenvatinib has decreased from 40% to less than 10%. While atezolizumab increased from almost less than 7% to 70% following the approval. So the increase in usage is basically because they have insurance, they have capacity to, the insurance are usually funded, and most of them can afford atezolizumab because of that, which may not hold true for Indian settings. Whether it's feasible, we heard the inclusion criteria previously, that it's untreated HCC, child PUB-A, good performance status. Yes, these are the ones who benefit more from any of the systemic therapy, be it sorafenib, lenvatinib, or atezolizumab. But is it possible? Most of our patients in the real world scenario present when they have they're in child C or child B, that almost 40% in child B and 9% in child C. This is a large study from PGI, or for 800 patients. So 40% in child B and 10% in child C. Choosing it's very difficult for these patients. We had a similar experience from South India as well. We had around 63 patients who received lenvatinib. Again, child B constituted 56% of the individuals. Less than child, at least up to 8. Score was included here was 8, and we see around 55% are in child B. That's the major concern. It's not different in US, but US also has a similar data. This is a large study of around 1,600 patients. That child B were around 34% and child C were 16.6%. So then came an article in Hepatology of Liver Journal, which said that preliminary evidence of safety and tolerability of atezolizumab in patients with HCC and child PUB-A and B, the real world data, for which there was a beautiful letter written whether we should extend the boundaries of our treatment for HCC. This study said that child A and B have comparable progression-free survival and overall survival without any added adverse events in child B. But this doesn't happen usually in our practice. These are some few cases which we have seen in our practice. This is a 68-year-old male with good performance status, NASH-related cirrhosis with alpha-fetoprotein of 2000 plus, bilirubin 1.3, albumin 3.4, child CTP 7B. He was not quite keen for any of the procedures or liver transplant due to personal issues and personal beliefs. So he was not at all willing for any transplant. So we gave him just 3 cycles of immunotherapy, following which there was complete resolution of the tumor. We also continued him for next 3 cycles, and now there is complete disappearance of tumor, and alpha-fetoprotein here now is 7.3. The good step, child B, 7B, good performance status, probably responded well for this. But this also doesn't happen quite often. We have a second patient, 70-year-old male, good performance status, alpha-fetoprotein of 171, was diagnosed with HCC, started elsewhere on sorafenib, presented to AIG, had a bilirubin of 3.8, albumin of 3.2, no potential donors, already listed for transplant elsewhere. He had tumoral thrombosis also. Then our question was whether we have to continue sorafenib, stop with sorafenib and switch to immunotherapy, do a TACE, do a TARE. He was 70-year-old. Family was like reluctant for transplant. They were like, we want to wait for a cadaver. The bilirubin was high. In the bilirubin is high, usually we don't tend to continue any of the tyrosine kinase inhibitors or the immuno-oncological agents. So we stopped the sorafenib, waited for 2 weeks. His bilirubin reduced to 2.1 milligrams. Then we planned for TARE, post-TARE, and 3 cycles. After around 2 weeks, we started him on atezolizumab. After 3 cycles of atezolizumab, almost all the resolution of the tumor. This is almost after 6 cycles, the tumor completely resolved. The tumoral thrombosis also resolved. And recently, when we did a PET scan after around 1.5 years, almost around 9 to 10 cycles of atezolizumab, there is no lesions. He has decompensated by because of the existing NASH cirrhosis, and he developed SBP as well. And then he is again waiting for transplant, being elderly patient. it's quite difficult to get a cadaveric livers in such a situation. He lived for almost around 1.5 to 2 years, and he's okay. The questions in this scenario is whether age is a barrier. Why did we do TARE plus atezolizumab? How long should we administer the therapy? Can we switch to tyrosine kinase inhibitors post atezolizumab, and how to assess the therapy? Is CTP-B a good choice? This was a study published in Liver International, including less than 65 years and more than 65 years. They said that there is comparable overall survival and comparable progression-free survival if the patient is elderly after using atezolizumab. So age is not a barrier for this drug. Why did we combine TARE plus atezolizumab? When we do a TARE, we know that NASH especially has a heterogeneous microenvironment and poorly responds as per the initial data published in NEJM, saying that NASH may not be a good patient for atezolizumab. And it was also held true in 2021 Nature paper, saying that the microenvironment is not good for NASH patients to receive atezolizumab. But when we do a TARE, there is increased antigen expression. When this antigen expression is increased, we give atezolizumab and the tumor is suppressed. There is a large RCT underway on TARE plus atezolizumab versus TARE alone. How long should we continue? It's basically in India, it depends on the finances, but recommended is to continue until the disease progresses. These are several of the studies which have been done, varying between 3 to 6 cycles, a median number of cycles. The maximum was around 27 cycles, which was given in one of the studies. So 6 cycles probably should be okay for considering the Indian settings. And how to assess the therapy 9 to 12 weeks after around 3 to 4 doses, we get a CT or MRI, and if affordable, PET scan to assess for the metastasis. But we said everything, but we did not say about alpha fetoprotein. Yes, alpha fetoprotein is also a good predictor of response. It is less than 400 nanograms at baseline, and it creates a good overall survival and progression-free survival. While a decline at 6 weeks, we will check the alpha fetoprotein. If there is decline 30 to 50%, then we say that the patient may respond well to the therapy. There are several other predictors of the response, but most importantly, what we see is prior local original therapy, low alpha fetoprotein at baseline are the most important predictors of therapy of our atezolizumab. Next, we come to the real-world experience. Our experience published recently, we had around ours and Mahatma Gandhi Hospital, Jaipur, were included in this study. We had around 67 patients who received atezolizumab. We wanted to assess the overall survival among different child classes and determine the progression-free survival and adverse events in Indian cohort. Interestingly, what we see here is the age here is 61 years. Previously, it was actually a little more. Now, the etiology is NASH. Dominant etiology is NASH. There are two things about this. One, NASH probably is rising in India. Second, NASH are the only ones who can afford atezolizumab. And viral markers, hepatitis B and C contributed to almost around 23 patients, 24 patients. But the most common dominant etiology was NASH in this group. Some of the patients had received prior therapies in the form of TARE or TACE or microablation for the adrenal mets. One of the patients also received immuno-oncological agent atezolizumab post liver transplant. There were 7 patients in child C, so 36 patients in child B, and 24 patients in child A. We noted that overall survival is much better in child A, that is 21 months. B was only 9 months. C was only 4 months. The significant difference in this overall survival and progression-free survival, PFS was around 18 months in child A, 8 months in child B, and 2 months in child C. So definitely it all depends on the child PUC score, as discussed with the previous speaker as well. And there are several other studies saying that child score is the one which determines the outcome of these patients of progression-free survival and overall survival. These are all the Kaplan-Meier survival curves from the different studies. What we noted was adverse events were quite common in child C. To some extent, grade 3 adverse events were little higher in child C compared to child A and B. Importantly, the one which is we are scared almost always is the variceal bleed. 2 patients had variceal bleed. One had history of variceal bleed prior to therapy, and once we initiated therapy, again developed variceal bleed. We switched him to only atezolizumab alone, but he could not tolerate, and after around 3-4 months, he had progression and he expired. The second patient had major portal vein thrombosis. He bled after 4 cycles of therapy. We stopped again bevacizumab and continued atezolizumab for next 3 cycles, and then he had a disease progression. Whether we should do endoscopy for all? Yes, endoscopy has to be done for all, but prophylactic banding for all, my personal opinion would be a little skeptical. If the patient has large varices and the portal vein thrombosis, I would not be preferring to do a banding, because if you band them, most of the patients have a rise in portal pressure, and post bevacizumab, they have a high tendency for bleed. This was an article published in CGH, a good decent journal from US. 194 patients, who 102 had a EGT prior to therapy, and 8 patients had bleed, and the time to bleed was 1.8 months. 17 patients had high risk varices, only 8 patients had bled. Importantly, what they noted in multivariate analysis was only the presence of main portal vein thrombosis increased the risk of bleed. Prophylactic EVL did not reduce the risk of bleed. So the presence of portal vein thrombosis is the major contributor for variceal bleed post-therapy. In summary, immunotherapies, atezolizumab is an excellent treatment option for unresectable HCC, of which the one available in India is atezolizumab. Choosing the right patient is the key to success. Child up to 8 is okay, not more than that. Combination therapies, in the sense local regional therapy plus the immuno-oncological agents, are much better. Variceal bleeding is actually less than feared, and STRIDE probably yet to come to India, but has to be compared with atezolizumab, how it fares. The only drawback with this drug is the cost. There's some of the disclaimers from the Roche. Thank you.
Thanks, Dr. Anand. That was a wonderful presentation. I have one question for you.
Yes, sir.
So, how do you choose the patient whether to go for TARE or TACE? Or now, Dr. Basant also presented a TACE with sorafenib would be better. So now we have a lot of options, plethora of options. So how do we choose individually?
It's an excellent question. Actually, TACE we do when the patient doesn't have portal vein thrombosis. If the patient has branch vein thrombosis, we may do a TACE. The patient has a main portal vein thrombosis, we never do TACE, because they decompensate post-therapy, post-TACE. So TARE, the lesion is less than 8 centimeters localized, we do a TARE. SBRT, if the patient has multiple diffuse lesions throughout the limited to liver, with or without portal vein, then we do SBRT. There is no data on SBRT plus atezolizumab, as I see a question over there. But we haven't tried SBRT followed by atezolizumab, because SBRT we do for a limited number of patients, and here we often do more than SBRT.
Nice. Thank you. Thanks for that answer. Is there any question from audience? Let us know, so that Dr. Anand will be happily answering it, or we can, interest of time, we can put it in chat box so that we can reply back. Thanks, Dr. Anand, once again for that excellent presentation.
Thank you.
So we'll next move upon to presentation, study of palliative RT for symptomatic HCC. Dr. Meghala. Dr. Meghala is a senior consultant radiation oncologist at Narayana Hospital, Mysuru. Over to you, Dr. Meghala.
Am I audible?
Yes, ma'am.
You are very much audible.
And where can I see the slides?
Technical team. Geetika.
Okay, sir. Can I run?
Yeah, please.
It's visible, ma'am?
Yeah, it is. Okay, thanks. And firstly, thanks to Dr. Srinivas for giving me this opportunity. And as a radiation oncologist, I think we don't want to leave any stone unturned in the treatment of hepatocellular carcinoma. So on one end, we heard about SBRT. I think on the other end, this is a trial, a phase 3 trial, to study how palliative radiation helps in treatment of symptomatic hepatocellular carcinoma, whether it is from primary or from a metastatic one. Next slide. So the hypothesis here is that if we try to understand the cause of liver pain, It's pathophysiologically, it's because of the tumor mass within the liver that stretches the capsule. The moment the capsule is stretched, they have pain, and that could be quite severe. So the hypothesis is systemic therapy may not be able to give a very quick pain relief, and opioids may not be having a very good therapeutic window in terms of clearance and in the presence of underlying liver disease. So if you look at the timeline of palliative radiation, it has been time and again used and given up, used and given up, and this time again it has been resurrected. I think probably the reason is there were concerns about radiation-induced liver disease, RILD, which is a veno-occlusive disease, and not having a very good understanding of the partial volume liver tolerance or the whole liver tolerance as such. In spite of that, from 1900s, people have been using whole liver radiation for palliation in various fractionation sizes, but in this trial, they've tried to do it in single fraction. Next one. So in this, they are basically comparing a single fraction radiation to the whole liver. The other arm being no radiation, they only get best supportive care. And what they are looking for is if there is any pain improvement with radiation versus best supportive care, as determined by the brief pain inventory. There should be at least 2-point improvement from the baseline. And the secondary endpoint was survival at 3 months. Next slide. So if you look at the patients that have been chosen for this, or the inclusion criteria, it's generally patients who have tumor burden within the liver, occupying more than 50% of the liver, or the whole liver studded with metastasis more than 10, to be precise, and or something that is more than 10 centimeter with vascular invasion. And also they are probably suitable for local, regional, or other form of systemic therapy, with definitely with underlying good, reasonably okay liver function. They get randomized to either best supportive care or a single fraction of whole liver radiation, and then pain is assessed at the end of 1 month and 3 months. So because we know that upper abdomen is very, very sensitive to radiation, and we're giving a high dose radiation, they need to be heavily pre-medicated with dexamethasone, granisetron. Okay, next slide. So this is the brief pain inventory. The box marked in the red shows how the patients had to mark. So 10 being worse, and any 2-point reduction in the pain is considered as improvement. So in this trial, the maximum recorded pain was 7. Next slide, please. Okay. This is a picture to describe the kind of radiation that they have used. So they have just on the left-hand side is the conventional radiation plan, whereas on the other side is an intensity modulated radiation plan. It would definitely depends on the comfort of the planning radiation oncologist and the physicist. Next slide. So what they saw was they treated about 60, they were able to randomize 66 patients. So 43 were metastatic. So of that, you can see majority is colorectal, followed by breast, pancreas, lung, and others. And 23 were from primary hepatocellular carcinoma, with a performance status of ECOG performance status of 2 or 3. And Child-Pugh score was at least A in 64% of them. And the next two volumes are indicative of the amount of liver volume that was being treated. And you can see that 42 completed treatment and 1 month assessment, and average baseline pain score at worst pain score was 7 on 10. And probably because of better pain relief with radiation, 11 patients migrated to the radiation arm from the best supportive care arm. Next. So if you look at the last row, for all patients from the worst pain, 2-point improvement from the worst pain was seen in 49% of patients in the those who received radiation versus only 12% who received best supportive care. I'm not very sure what they mean by best supportive care in this, but this radiation compared to best supportive care was definitely significant, statistically significant. Next one. Also, I'm not sure if we can assess overall in a trial done on such advanced patients receiving palliative treatment. However, at the end of 3 months, they were able to see there was a slightly improved survival, 51 versus 33% in those who received single fraction radiation. However, no statistical significance can be made. Next one. So the conclusion was single fraction, 8-grade single fraction relieves improves hepatic pain in majority of the patients with end-stage painful HCC or liver mets, with a trend to improved survival. Next one. This is basically the repetition. The point also to be noted is that they say there was 25% reduction in the opioid use at the end of 1 month. Next slide. You can go to the next one. So the other thing that was assessed was the quality of life scores based on the FACT hepatobiliary scale, and there was a trend to improvement in the quality of life at 1 month. We only with respect to hepatobiliary scales. The other FACT subscales did not show any improvement, and the adverse events, more than grade 2 adverse events, was 58% with radiation and 33% with best supportive care. More than grade 3, which is usually considered as significant, were uncommon. Probably the grade 1, grade 2 adverse events could be nausea, vomiting, fatigue, and the similar ones. Next one. So I think that's the end of my presentation. I'll be happy to take any questions.
Thanks, Megla, for that wonderful presentation. I have a question for you. Do you think that radiation in HCC, which we never thought, okay, radiation benefit would be evolving in these patients? I had actually one patient 15 days back. I don't know how many grays they have used. The initial AFP was something like 2000. One of the radiation oncologists actually referred to me. The radiation it is a multicentric HCC to begin with. Started giving radiation as a palliative intent. Then after radiation, they came to follow up in my clinic. We repeated AFP. AFP is 4.
Oh,
I was shocked, asking that what treatment you had before. So he told I had a 15 to 20 days of RT in one of the hospitals in Bangalore.
Okay.
So what I'm trying to tell is radiation, so-called radio-resistant tumor HCC, what we used to talk all these days. I don't know. I think more and more studies has to come now, and the radiation benefit is evolving in HCC. To begin with,
I can understand what you're trying to say. Yeah. So even, I mean, if you look at melanoma, even they were considered as radio resistant. But of late, we have stopped using the word radio resistant. And what we use is moderate, mildly sensitive, moderately sensitive, and very sensitive, you know. So I think we will assume that all of them have sensitivity to some extent. And the other question where the AFP came down, it sounds very good. I think what has to be kept in mind is the whole liver can tolerate up to 30 gray. So however you fractionate, as long as you respect that, especially in these people who have a decompensated liver or something, I mean, the aim is to relieve pain and not give them any kind of, worsen the hepatic failure or anything. So that is kept in mind. I think Also, probably there must have been some obstructive component which has helped to reduce so many possibilities.
So now the role of SBRT in HCC, the role of palliative RT in HCC, so many things are coming.
Yes.
I think the radiation oncologist again will become very busy now. So far we used to consider, okay, radiation oncologist doesn't have any job when the patient comes with HCC. I think now this is a reopening kind of thing. I think again, radiation oncologist will be a part of the HCC treatment, and any HCC meeting, I think radiation oncologist would be there in future, because this is evolving. It's something very good to know, isn't it?
True, true.
Thank you so much. Thank you so much.
Sir. Thank you. Thank you.
Yeah, fine. Next. I think we'll move on to the next topic. Dr. Vijit Shetty, consultant medical oncologist, a good friend of mine from Mangaluru. He'll be presenting SWOG 1815, phase 3 trial of gemcitabine with cisplatin plus nab-paclitaxel versus gemcitabine with cisplatin newly diagnosed advanced biliary tract cancer. Dr. Vijit, thanks for joining us. Over to you, Dr. Vijit.
Thank you. Thank you for having me here, Dr. Srinivas. I hope my slides are visible.
Yes, sir.
Thank you. So I'll be quickly running through this phase 3, which looks like a quite important study at the outset, where they're combining gemcitabine, cisplatin, and nab-paclitaxel, and comparing it with the standard of care gemcitabine and cisplatin in newly diagnosed advanced biliary tract cancer. So biliary tract cancer, as you know, comprises of cholangiocarcinoma, both the intrahepatic as well as extrahepatic, and gallbladder cancers. And as we know, this is not just confined to the Gangetic belt in India. We are seeing quite often these malignancies in our setting as well. So gemcitabine cisplatin has been the standard for a long, long time. And even with the addition of IO, like durvalumab, the median OS is still only around about 13 months, so 12.9 months as per the TOPAZ study. So is there anything which we can improve on? Is there any way by which we can improve on this survival? So that question, the answer we were seeking in this trial, they were seeking in this trial, the SWOG study. So they were trying to see if the triplet combination of nab-paclitaxel, gemcitabine, and cisplatin, or from now on we'll call it GCN, demonstrates better survival or response rate in comparison with gemcitabine cisplatin alone. So this was a very promising phase 2 study of 60 patients in a single arm trial compared with the same group, SWOG group, and they found very encouraging results in this phase 2 study. So they went ahead with this phase 3 study. So this SWOG study had a 2:1 randomization of newly diagnosed, histologically proven, untreated biliary tract cancers who were having excellent performance status. This was in the first line. The experimental arm or the study arm had gemcitabine in the dose of 800 milligram per meter square, cisplatin in the dose of 25 milligram per meter square, and nab-paclitaxel in the dose of 100 milligram per meter square, day 1, day 8 of every 21-day cycle. Comparator arm had the standard gemcitabine cisplatin, and the target hazard ratio was 0.7. Secondary endpoints were overall response rate and PFS. So every 3 cycles, the patients were restaged until progression. And the primary endpoint was overall survival. Pre-specified stratification factors included the site of the disease, namely intrahepatic or extrahepatic cholangiocarcinoma or gallbladder adenocarcinoma, and they were again the subset was seen for locally advanced and metastatic disease, and performance status wise they were subdivided. As we can see, both the arms are very well matched. The 2:1 randomization ensured a higher patients in the GCN or the experimental arm, and predominant patients were females, and the races were well matched. And of the lot, the number of patients with intrahepatic cholangiocarcinoma were slightly higher in both the arms. As we can see here, the GCN arm had a higher response rate or overall survival rate compared to the GC arm. And also in terms of PFS, there was a slight numerical edge with the combination arm. So although no significant difference was seen with this GCN versus GC by disease site, there was a small trend towards better survival with the gallbladder subsite. The numbers were very small, so it was very difficult to make any interpretation. Also in terms of median OS, this has actually gone beyond the TOPAZ study, and the locally advanced In them, the median overall survival was 19.2 months compared to gemcitabine cisplatin. In the locally advanced setting and metastatic setting was around 13 months. So almost on par with TOPAZ. Also, PFS was slightly better in the GCN compared to the GC arm. Overall response rate was numerically higher in the GCN arm compared to the standard GC arm. And in terms of subsites of the disease and stage of disease also, GCN fared better vis-a-vis the doublet arm of gemcitabine cisplatin. Having said all of that, patient had much higher incidence of grade 3, grade 4, and grade 5 toxicity in the triplet arm, with higher incidence of myelosuppression, diarrhea, fatigue, sepsis. There were a few incidences of cardiac arrest as well, and life-threatening toxicity in the GCN arm. So, to put things in a nutshell, addition of nab-paclitaxel to the doublet arm did not actually greatly improve the overall survival in newly diagnosed advanced biliary tract cancer. Although there was a higher response rate with this combination, but it did not reach statistical significance. There were much higher grade 3 to grade 5 toxicities in the triplet arm. And also the exploratory analysis with higher response rate with locally advanced gallbladder cancer possibly suggests if in a better patient with a better performance status with gallbladder only histology young patient, maybe we can explore role of this triplet combination in the future. And we do need much better biomarkers in the future to help us select which particular patient will benefit from this triplet combination. So I think that's the end of my slideshow, and I will be happy to take any questions.
So what do you feel, Vijit, triplet has any edge, or do we need to have any selection strategies to choose a triplet? What's your opinion?
So I think given the choice, I think most of our colleagues will go for the Durva and Gemcis combination if possible. But I think because mainly because of the higher toxicity profile with this triplet combination. So probably in a young patient who probably cannot afford IO, young fit gallbladder only disease, gallbladder with maybe a higher tumor burden, higher nodal burden, maybe that is one patient where we can think about using this triplet combination. Again, we'll have to be very, very careful about the side effect profile. But I think in a young fit patient, it can be tried.
Absolutely. But as you said, though Durva, we have a lot of good data now. The next half an hour, Dr. Amit Rautan is going to highlight the role of Durva in these patients. But the practical burning question always is affordability, the cost. So how many of our patients can afford Imfinzi, that too of 1500 mg with jumps? Exactly. Is a very an important practical situation. So and as you rightly said, probably a very young patient fit who can hold the toxicities, probably they are the patients. Something like FOLFIRINOX in pancreatic, we don't give FOLFIRINOX to every other patient. So I think choosing the patient may be a right strategy to go. Anyway, thanks, Dr. Vijit, for the presentation. So now I call upon Dr. Ravi Tippeswamy, the senior consultant medical oncologist, to present IMbrave 151, a phase 2 randomized trial of atezolizumab with or without bevacizumab in combination with chemotherapy in biliary cancer. Over to you, Dr. Ravi.
Yeah, thank you, Srinivas. And I think the previous talk was very good because in the era of immunotherapy, they have tried something like chemotherapy, which probably practically useful for us. Now we will discuss the standard and the present standard of care, and it is going to become the standard of care in the future. The phase 2 randomized study of bevacizumab in combination with atezolizumab and Gemcis in patients with advanced biliary tract cancer. Next slide. So as we all know, biliary tract cancer is the second most common primary liver cancer. If you see the incidence and mortality, it matches because it is one of the disease which worst prognosis. So there was a significant unmet need due to the aggressive biology of the biliary tract cancers. And earlier what we used to give is say gemcitabine platinum or gemcitabine capecitabine, some doublet chemotherapy but with a lot of toxicities. Then came the split dose of cisplatin. So we give cisplatin nowadays day 1 and day 8 in all these hepatobiliary malignancies, which is well tolerated. And in the TOPAZ trial, it was shown that when we add durvalumab to this GEMSIS, again, the median overall survival improved. In this study, we will see whether adding one more drug, that is a VEGF inhibitor, bevacizumab, to the TOPAZ arm will make any difference. Next slide. So as we all know, it is a synergistic combination. We have seen this will work in HCC, and I think HCC almost all of us have a good number of patients, which shows very good response to atezo-bev combination. So whenever we do a blockade of VEGF coupled with cytotoxic chemotherapy, it will augment the response of a PD-L1 inhibitor. So this was the basic rationale why they combined atezo-bev with chemotherapy. Next slide. So coming to the study design, it was a pretty straightforward study design where histologically confirmed cholangiocarcinoma, it can be intrahepatic or extrahepatic, with good performance status in first line. They were randomized to receive in one arm the TOPAZ trial arm, that is GEMSIS with instead of durvalumab, atezolizumab, and the second arm was GEMSIS with atezolizumab combined with a VEGF inhibitor bevacizumab. So it was a 1:1 randomization, and the primary endpoint was PFS. Next slide. So I think inclusion criteria we have seen. If you see the key exclusion criteria, mainly varices, because we are using an VEGF inhibitor bevacizumab. So if there is a history of bleeding episode, we should be cautious. And if there is any vascular event in the last 3 months, we should be cautious. Next slide. So the baseline characteristics was well matched in both the arms. Even if you take the PD-L1 percentage expression, the metastatic disease, it was well balanced. Next slide. Coming to the results, if you see the primary endpoint, you can see the curves. Though it is well separated, but if you see the delta, that is magnitude, the median PFS when we add bevacizumab to the combination of atezo chemo, the median PFS was 8.3 months as compared to 7.9 months with a hazard ratio of 0.76. If you talk in terms of absolute number, the trial may not be direct practice changing, but considering the biology of the disease, aggressive nature, where we don't have much option, almost all the patients giving second line treatment is very difficult. So this is one of the good combination to consider in the present scenario. Next slide. So coming to subgroup analysis, if you see the forest plot curve, almost all the patients got benefited, though the lines are crossing the median because of the prognosis here. If you see the delta, as I discussed, the median PFS was hardly any difference between the two arms, if you talk in terms of absolute numbers. Next slide. Coming to the secondary endpoint, objective response rate. If you see the stable disease, which were the majority of the patients, again, when we add VEGF inhibitor to atezo plus chemo arm, they did well as compared to the atezo without bev arm. Otherwise, both arms, the objective response rates, CR, PR were more or less similar. Next slide. Coming to the duration of response, again, we are seeing the suppression of the curves, but if you see the magnitude of benefit, it is minor improvement will be there when we add an VEGF inhibitor. Next slide. Coming to the overall survival, in the experimental arm, it was not reached as compared to atezo plus chemo arm. It was 11.4 months. And even if you see the curves at the end of, say, 11 months, they are touching each other. That means probably we may get some minor benefit. Next slide. So this was an exploratory post-hoc analysis, which again signifies that whenever we are adding an VEGF inhibitor to an immunochemo combination, slightly the magnitude of benefit will be better. Next slide. A safety summary, we all knew that it was a well-tolerated combination because we had good experience with HCC, the atezo-bev. But here, when it was combined with chemotherapy also, there was not much any exponential increase in toxicity. So all the toxicities were within the expected this one. Say whenever we add an VEGF, what was the toxicity expected? So that was the standard toxicities, what it was seen. Next slide. Again, it is the same adverse events of grade 3, 4. If you see numerically, they are all in single digits, which is a well-tolerated combination. Next slide. So to conclude, IM Brave 151 is the first randomized study to evaluate an PDL1 plus chemo with a VEGF inhibitor. The addition of bevacizumab to atezolizumab plus chemo modestly improved the PFS with a hazard ratio of 0.76. As I told, the delta magnitude of benefit is not that great. The median PFS was similar in both arms. And the landmark 6 months PFS was higher in the bevacizumab arm. The objective response rates were again similar. The duration of response were slightly numerically better. So the OS data is yet to mature. What we can conclude from the study is it is a well-tolerated combination. So it is feasible in our day-to-day practice. And as I told, the biology of the disease is very bad. So as we have experienced in HCC, before the atezo-bev combination with only TKIs, the benefit was very limited. So probably once the OS data matures, this is one of the combination to be kept in mind while discussing with the patient. So with this, I will conclude. Thank you.
Thanks, Ravi. Thanks for that wonderful presentation. Now, today we have a lot of discussion we are going to have. Dr. Amit is going to moderate the session on how to manage a patient with biliary tract cancer. And Dr. Ravi, I want you to stay, join as a panel. Now I request Dr. Amit Rautan, Senior and Head of Medical Oncology, Manipal Hospital, Bangalore, to moderate the session on updates in the management of first-line biliary tract cancer. Dr. Amit, sir, are you there?
Yeah, hi. Good evening.
How are you, sir?
Good evening. All fine. Thank you.
Welcome you, sir.
Thank you for the
So,
invitation.
so in our panel, I think we have Dr. Aparna, Dr. Naveen Anvekar, Dr. Vijit Shetty, Dr. Ravi Tippeswamy. These are 4 medical oncologists. And Dr. Vijay, our oncosurgeon from Bharat Cancer Hospital, Mysore. Dr. Vijay, are you there?
I am here.
Dr. Vinay is a radiation oncologist from Bharat Cancer Hospital, Mysore. Dr. Vinay?
Sir, I'm there.
Yeah, thanks. So over to you, sir.
Right. Okay. Thank you. Thank you very much. So, okay. So, right. Is the screen visible?
Yes, sir.
Yes, sir.
Right.
So you're mute.
Right. Okay. So, so we are going to discuss management of biliary tract cancers, and this is changing so rapidly. Biliary tract cancer has become almost a different disease for us. So let's start off. So Aparna, I'll start with you. How are you nowadays looking at biliary tract cancers classification? When you look at anatomically, how do you classify these patients?
Yeah, usually we classify it as whether, I mean, from a practical point of view, whether it is operable, is it localized, is it locally advanced and metastatic. I think that's my way of looking at it, sir.
Right. So definitely when the patient comes to us, we are looking at whether it is a localized disease, it is a metastatic disease, operable. So for us, that becomes a very important decision point when we come to it. Dr. Naveen, what about the look of it from looking at it as anatomically? How do you distinguish these groups nowadays when they come to your patients?
As you have put in the diagram itself, as per the latest ESMO and
I think
intrahepatic in different details. Hello, sir.
Right, we lost you in the middle, Dr. Naveen.
Okay.
Yeah, now we can hear you.
No, is there in that?
Oh, okay, I think Dr. Naveen, we are losing your voice in and out suddenly. Okay. Right. Okay. Not a problem. Dr. Vijit, how are you looking at it? And when you see patients who come to you in the OPD, you kind of very important to distinguish these, or we club them how we used to do earlier. We never used to bother too much. For us, every biliary cancer was biliary cancer.
So, I mean, I think we're supposed to distinguish it now, sir. But practically, when I see, I just, like Dr. Aparna said, look at it whether it's operable or inoperable, and if the patient is fit to undergo some form of treatment or not. So, though I think we're supposed to look at the subside, but I mean, it has not changed my view towards a patient with gallbladder cancer or intrahepatic cholangio. What matters is probably how fit he is to undergo what form of treatment. So, I'm not really looking too closely into the site of origin, because most of the time they're studied with meds everywhere, and whether it's intrahepatic or extrahepatic, at that time it doesn't really matter to me.
Right. I agree with you. I think even all of us used to just see biliary cancers as biliary cancers, and that's how we used to always kind of put them all together and not bother too much. But I think now we are moving to this era where we have to really look at which type of biliary cancer we are looking at also. Dr. Vijay, you are the only one who really would be looking at all this very, very closely, because you have to operate them. So you can tell us about this in detail first.
So I have some because like distal CB lesions are very much operable, and usually they present with jaundice, and they carry good prognosis compared to intrahepatic cholangiocarcinoma like that. And even gallbladder cancer, like they present early presentation or incidental thing, I think they are pretty good and they carry good prognosis. So rather than combining as a whole, we have to differentiate the site as well, whether it is gallbladder or intrahepatic cholangio or extrahepatic cholangio, or whether it is distal CB. After the site classification, then we have to, as before speakers told, like we have to classify whether it is operable or inoperable, then we have to carry forward.
Right. I think that's the way all of us as medical oncologists are now learning later. For us, we never used to bother too much, but as you have said now, we also have to quite look at every patient who comes to us and classify them and tell them which type of biliary cancer they are.
Site carries different prognostic.
Absolutely. So now we are learning that the treatment is different, the prognosis is different. Medical management was not very different. That's the reason we never bothered too much, but I think now it's getting more and more important. So I think this picture tells us everything about it. Intrahepatic, and extrahepatic. Then there's the perihilar and gallbladders come under our extrahepatics. They come with a similar kind of treatment approaches and outlooks. So we've seen how we stand in biliary cancers. One of the most disappointing diseases to treat, especially if you get patients in the advanced stage disease. We have seen that the median survivals in most trials have been anywhere ranging from 10 to 12 months. And that's about it, is what we have always got. And though GEMSIS has been our standard of care, we have seen our 5-year survival rates is less than 10%. It's very, very few patients of biliary cancers in advanced stages you'll really see very long in our OPDs. And we always said in India, we are a big belt of biliary cancers, especially if you look at gallbladder cancers, there are areas in India where the incidence is really very high. So coming on to what incidence do we see in our practice, and what types of biliary cancers we see much more commonly? Again, Dr. Aparna, what types of biliary cancers are you seeing much more commonly? How is your incidence rate in practice clinically? We all are from different parts of Karnataka, and all of us see different rates of biliary cancers is what we have seen in our experience.
Sir, I haven't analyzed my data. I can't be very sure, but I can say that maybe around 5 to 10% maybe biliary tract. And usually I see these periampullary carcinomas and gallbladder also. And even this cholangio also we do see regularly, and most of them are advanced stages. So usually I don't get operated cases. I get these patients who have undergone ERCP and then come for locally advanced or metastatic cases.
And Dr. Aparna, are you seeing in the last few years the numbers have gone up? Don't you think so?
Yes, sir. Yes, correct, sir. Yeah.
Even we are noticing this. The numbers of biliary tract cancers have definitely gone up in the last few years. Dr. Ravi, what about you? Do you see more of these intrahepatic cholangios, or the perihepatic, or gallbladder cancers are much more in your practice?
Yes, sir. Now, as you rightly told, the incidence has increased significantly, and it is almost matching or sometimes crossing the HCC, what we are seeing now. So definitely the numbers have increased. Then.
Yeah, I think you made a very good point. Even I believe we see much more bile tract cancers than HCCs. HCCs, we actually don't see that many as much as we actually talk a lot more of HCC, but we definitely see more biliaries than HCCs, I think, in practice. Dr. Vijay, to operable patients come to you, which segment do you see much more?
So commonly, in my practice, I commonly see distal CBD lesions, sir. And rest of the lesions, what I get is all locally advanced. For example, gallbladder and liver cancers, they present in advanced stage. Distal CBD, they present in early stage. So, and nowadays, as you told, like biliary tract cancers are quite increasing.
Right. So even distal is where you see the ones that come with obstructive jaundice. I think then they come to you.
They present early, so we will able to catch up them in early stage.
Right. I kind of think, yeah, that's the way it would come for operable patients for surgery. Dr. Vijit, what kind of presentations you are seeing for patients of this kind of biliary tract, which are more common?
So I am seeing actually a good mix of gallbladder and intrahepatic cholangiosis. So of late, a lot of patients do end up with a gastro, come with obstructive jaundice, and then when they do the stenting, and then they find out that there's a cholangiocarcinoma. So most of them are locally advanced or metastatic by the time we see them. So yeah, locally advanced and metastatic, like Dr. Aparna, I agree with that. So see a lot of them, but off late, couple of gallbladders and early stage also I have seen the T2 and 0 type. So I had to again relook at the guidelines about the role of adjuvant. So yes, I think we are coming across a lot more gallbladder than we used to earlier.
Agreed.
And socioeconomic status, sir. I think socioeconomic status I'm seeing across all boards, sir. Initially, probably I was seeing more in the low socioeconomic, but now I'm seeing more in the across all the socioeconomic status.
Right. So I think that's one point, good point. We are all seeing in every group of patients these. Some we see more of intrahepatic, some we see more of gallbladders, but all of us are seeing that way. Dr. Naveen, this question of performance status becomes very important when we see patients in clinics, because all our clinical trials will talk of very good performance status patients, and then patients going through second-line therapy and third-line therapies. How do you think are your patients, when you see either most of the biliary tract cancers, what performance status are you seeing them, and which subtypes do you believe you see more?
Usually, if you include all this one hepatobiliary tumors, this one biliary tract, they comprise around 30% of my cases, and most commonly it is intrahepatic cholangiocarcinoma, and they come in the advanced stage with hepatic metastasis, and mostly in poor this socioeconomic status. Maybe it is a referral bias, and the performance status usually 1 or 2.
Right. So you do see a good amount of cholangiocarcinomas, and as usual, most cholangios are in advanced disease. That's the way most of our presentations has been. I would say our good performance status has been a little less, but yes, most of them would be 1 or 2. I would agree with that. Okay, so patient journey. This is something it is important especially if you see an early biliary tract cancer. Dr. Vijay, I would put it to you. Could you tell us a little bit, guide us about if patients came to you, how do you approach these cancers in the present era?
So, like usually, as I told you, like if the patient, usually the biliary tract cancer they present usually with jaundice and loss of appetite. So once they come with us, like usually, so after that, like know that I block. So
we are losing your sound.
Am I audible?
Yeah, now you are.
As I told, like many of patients present with jaundice and loss of appetite. And
I think we're losing your sound. We're not able to hear. Okay, by the time we come back to you, I think let me ask Dr. Aparna. So when they come to us, we are in a trouble because we don't know so much about the other parts of management. So we always say, it's very easy to say, let's have a multi-tumor disciplinary meeting and understand what to do. Do you kind of think of these MTV meetings? Do you have any? Who all do you involve? What do you discuss with when these biliary tracts maybe early stage comes to you in the clinic, and then how do you approach it?
Sir, actually, for not every patient, we are doing tumor board. If there is anything unusual or atypical presentation, we do have tumor board discussions where a surgical oncologist, medical and radiation, oncopathologist, and our nuclear physician, we all sit together and we discuss the cases. And in Kidwai, they used to say when we were presenting that it is a periampullary carcinoma. So Linu sir would ask, has the pathologist seen whether it is arising from the CBD or the duodenal, what is the site of origin? You can't just say periampullary, you have to commit as to where it is arising. So we used to discuss so many things about periampullary or even cholangio, whether it is intrahepatic, extrahepatic, etc. But in clinical practice, whatever comes anywhere near bile duct, we usually put gemcitabine, and we add another agent, say oxaliplatin or capecitabine, and usually the treatment options, not many treatment options are used to be there. So it really was very theoretical to classify them as intrahepatic cholangio, extrahepatic, whether it is actually from the duodenal mucosa or CBD or actually pancreatic head also. So I think that is my take on this.
Right. No, I feel sometimes stage 4 management was much more easier. You don't have too many options, so you can easily choose what you want to. But early stage, whenever you get patients, it becomes a real. It's one of those stages where you have a potential to cure, and you really need to integrate the multidisciplinary team. And I think it's very important in this cancer, especially. And we can't stress on the fact that we need a good hepatologist or a good gastroenterologist who would actually do all those procedures, the ERCP stentings. Sometimes we need a good IR to do our PTBDs and foot stents for obstructive jaundice. And of course, we should have a team, as you already mentioned, of all the allied specialties so that these patients can be managed. Yes, yes.
Dr. Amit, can I join?
Yes.
Most of the time, what happens is it will be in a borderline situation where my surgeon says it is just inoperable. Give some kind of neoadjuvant, make it operable, and send it to us. So how do you deal with it? Actually, I get a lot of end up in this kind of situation where it is borderline unresectable kind of situation. Most of the time, that's what I see in my practice. How do you do that?
So one very tricky part is, we can do neoadjuvant therapy. It's not that we can't do neoadjuvant therapy, but whether our neoadjuvant therapy will really make inoperable operable is very, very difficult to say. So we are very clear with our patients that if our surgeons say they cannot operate at present for whatever reason, it's not clearly operable, we end up giving neoadjuvant chemo. I don't think the one thing about cholangiosis is a good segment of them are chemosensitive, and that's where my extrapolation of data is so that's my extrapolation. Though the trial is negative now, but for the last couple of years we're doing this so commonly. Whenever these are situations where I have fit patients, I do triplet, and I believe triplet gives you higher response than a doublet. I think anyway we will come to that data set also.
So what was your regime actually?
So we have the trial. We had a comparison of gem platin plus nab-paclitaxel versus gem platin. So and we have seen responses.
Vijit showed that data.
Yeah, so that data is clearly there, and we've seen the benefit in gallbladder cancers clearly there. It's a big benefit there. It's just that the intrahepatic benefit didn't come. But the phase 2 was really good, and we were following the phase 2 data for quite some time now. So this is something we do in practice. In that borderline situation, I lean towards that. But again, I would say as per data, GemCis or GemCis Durva may be the right way to go nowadays.
Yes.
So I think this is where the era is leading, and this is where we are all going to. I cannot stress the fact of how important molecular typing is becoming in biliary tract cancers. So let me ask Dr. Naveen, do you do testing, or you talk about testing? I know it's also new. We have just started doing things, all of us. So do you talk about testing? And if you do, what all do you ask for?
Yeah, though this one molecular, this one targeted treatment is we can get around 40% of intrahepatic cholangiocarcinoma, but most of these drugs are not available in India, except for MSI. This one testing for this one pembrolizumab. I don't think we have any other option as such. Even if you do this one testing, so will I really recommend it? Mostly after this one first line, I feel.
Right. So I know that's a major limitation. We don't have drugs, but at least if a biliary tract metastatic comes to you, what all are the tests you are asking for? At least that much you are doing absolutely.
Yeah, this one MSI we can ask for.
Yes, I think anything else.
And this one, if I'm not getting the name.
Okay, no, that's absolutely fine because we don't have most of the drugs, So that's why it becomes.
And this one IDH1 is there, and this one and
and all those are there. That's true. That's absolutely there. Dr. Vijit, what do you at the current time, are you testing your tumor for anything in biliary tracts? Any of the tests? Are you asking for any group of testing, Dr. Vijit? Oh, I think. Okay, I'm not able to get Dr. Vijit. Dr. Aparna, are you testing anything molecularly or any other testing?
Nothing much.
Yeah, if I may add, we routinely send NGS.
No, sir, I'm not asking for any.
Right.
Was it for me or Dr. Vijay?
Okay, no, I think we got parallel answers, but so you're saying no. Okay, right.
You can send for you can send
Can I add?
gene sequencing test for trial purpose.
Okay, trial purpose. So, no, okay, clinical trials are very difficult here. We don't have much trials, so that also becomes a difficult answer for us in our practice. Dr. Ravi, you are doing regular testing, I know. So what are tests are you doing for your patients, Dr. Ravi?
Yes, sir. So many of the time in the present scenario, we are doing NGS. That is a broad spectrum NGS what we are doing. And we have seen mutations. We have picked up HER2 and we have picked up ALK. And we have tried some of the drugs in the later lines, though the PFS magnitude is less. But definitely, if we get something like NTRK and all, it would be great. But as of now, probably in another 4 or 5 years, this will be the next lung. The entire treatment may be based on the molecular markers.
Absolutely. I think you are bang on, because I don't think we have that many mutations in any other cancer. 50% of patients will be having some mutation or the other which is targetable in bile duct cancers. So I think this is going to be in the next few years one of the most important ones. I conventionally, what I do in my practice, I test everyone for HER2/neu by IHC in all biliary tract cancers, and I do MMR as per what everyone has suggested. Because though MMR is very small, but HER2 is pretty big. And we have a good number of patients in our practice who are HER2 positive, doing very well on chemo trastuzumab. I don't even think we need to really go in huge, the fancy drugs. We still get good response with trastuzumab chemo. And I believe it's important in India because we have a lot of gallbladder cancers, and gallbladder cancers are the ones which are HER2 positive. So this is some data which will not come out from the West so easily. The numbers are smaller. So I think a good number of HER2 IHC testing is very straightforward for us. So that's one thing we are doing absolutely in all gallbladder cancers. But yes, even we are doing a lot of NGSs nowadays trying to pick up mutations. So,
Dr. Amit, I have a question.
Yes.
Do we need to do tumor mutation burden? Because you said 50% of the patients will have some kind of mutation. Should we also look for, because now we talk about a lot of immuno-oncology drugs in biliary tract cancer. What about TMBs?
So TMB is a very it's not one of the most straightforward markers. What you will understand is, so think of it this way: you have 50% having a mutation. Now, those of them, they don't have multiple mutations. So one which has FGFR has a dominant FGFR, right? Now, that means it doesn't have all the others. It will have FGFR, it will have maybe a P53, it maybe have some other loss, but nothing too much. So it may not end up having a very high TMB. Now, where we see TMB is if you have one cancer having multiple mutation types, there you automatically start thinking you're going to have high TMBs. So TMB per se may not be that great a marker for bile duct cancers. And I personally feel it's not going to be too important, because if your patient can afford immuno and you think you're going to give immuno, you are anyway going to give it first line in combination with chemo. So really, relevance of TMB will go down too much. So I don't think TMB plays too much a role, but I definitely feel the other mutations are important. So to complete the last part, very important, we are seeing differentiation molecular biology of intrahepatic versus extrahepatic and gallbladder cancers, and we should know this and we should always follow this. If it is intrahepatic, it is going to be much more of FGFRs, much more IDH1s, a small amount of P53s, a small amount of BRAFs, but those are the ones which are going to be IDH1 and FGFR. That's where we see it. We're going to see intrahepatic. I can sometimes say we can stretch and make a statement that if we pick up an IDH1 mutation, it's going to be a cholangio. It's not going to be anything else. So it's going to be an intrahepatic cholangio. So that's how common IDH1 is for intrahepatic cholangios. So we now say our molecular markers are different for intrahepatic, different from extrahepatic and gallbladders. For gallbladders and extrahepatic, the dominant one is going to be HER2. And that's why I keep saying we should do HER2s, because we are all gallbladder prominent country, and all our patients who have gallbladders are so common. So if we keep doing HER2 more and more, we will pick up more. And that's one, I think, target which is very encouraging now, because we can give trastuzumab chemo. But I think in the next 6 months, when trastuzumab and HER2 deruxtecan is there for us, I think that will also change our scope of gallbladder cancer management in future. So my thought is definitely look for HER2 in all patients, especially the gallbladder and extrahepatic types. So as everyone mentioned, the intrahepatic testing, we may find IDH1. So we have collected our pool of patients who have IDH, who have FGFR. We have all of that, but unfortunately we don't have drugs. So we are all sitting on those patients and waiting what to do for it, which is very sad as looking at the patient's point of view. But luckily, as Ravi has mentioned, you can get a few ALKs and they respond to ALK inhibitors. So that's really good. You can get, we have had a couple of patients who had BRCA mutations and somatic BRCA, and they have responded well to PARP inhibitors in gallbladder cholangiocarcinomas. So I think mutational testing is going to be there, and all of us will have to learn about it much more and do much more of it. Last thought on molecular, who do I put this to? Ravi, if you don't have tissue, which we don't have in cholangio so many times, what do? You do liquid biopsy or you don't do it?
Yeah, we do, sir, liquid biopsy, especially nowadays we are sending to Guardant, and I think it's a pretty good pickup rate.
Yeah, so that's one thing we are learning again. Cholangios, gallbladders, liquid biopsy is actually coming out very good. Your pickup rates of mutations, and we again, same way, you pick up FGFRs, you pick up IDH, you pick up HER2s. It's pretty good to do a liquid biopsy. Again, I wouldn't insist on that. I would say definitely do the easy way out first and then look at it. If you didn't get the answer, only then we move to that. So I think we'll kind of conclude this session saying molecular testing is very important, and all of us will be learning better and better. And as we keep doing, we'll build our own patient profiles. A quick word from Dr. Vijay. We lost you that time when you were talking of surgery. We just wanted your quick inputs on surgical aspects to it. And after Vijay, I want Dr. Vinay to talk about where we do radiation in biliary tract cancers. Where should we refer our patients for doing radiotherapy? Is there a role of adjuvant at all or not? So Dr. Vijay, first to you.
Sir, like coming to gallbladder cancer, usually we see majority of what we are seeing in my practice, like it will be after laparoscopic cholecystectomy from surgeon. So it usually like T1 or T2 lesions only. So what I do, like again, I'll for the CT scan and then see for any other node disease or any other advanced disease. We look for any laparoscopic findings. So then I take a call, like whether to go again and do. So basically, like up to T3 lesions, and if the nodes are not on port, we consider unresectable, then we do for go for radical cholecystectomy. And we usually wedge resection. And we usually send for frozen of a bile duct margin, confirm it is negative or not. If negative, then we'll go close it and then submit for purpose.
Right.
Then cholangiocarcinoma, usually intrahepatic, I have not seen any operable lesion till now. So usually multiple eccentric tumors. If we peripheral located, then we'll do liver resection or segment resections. If it is in hilar region, usually it will be any vascular involvement is there. It will be there. So usually intrahepatic cholangiocarcinoma, it is a bit tricky. Extrahepatic distal CBD, it will be very easy to operate. Usually we do Whipple's procedure for them, like hepatico-pancreatectomy, corridoco-pancreatectomy. And hilar, couple of cases have that is CT scan and
right.
One we subject for neoadjuvant chemotherapy as we discussed with Srinivas.
Right. Okay. So I think the approaches are very different for everything, and for us, for medical oncologists, we need to kind of talk to all of you always, and that's the only way we should approach the patient. And as I said again,
each site is different for us.
Absolutely. So anyway, I think we have all learned it that every operable patient, give them a chance of cure, and that's why we always say end up referring it to all of you and taking
all biliary tract surgery carries good prognostic.
Absolutely.
If it is operable, then prognosis is good.
Absolutely. So that's why we should emphasize and send them for surgical opinions and then say take the next step decisions. Dr. Vinay, which are the patients where we should think of adjuvant radiation and which subgroups among all these subgroups, if you can quickly tell us, because this is one knowledge we don't have. We always have this tumor discussion in the board. Should we have given adjuvant radiation sometimes, or should we not have go for that approach? What is the toxicity? And all these new approaches of SBRT which comes in, where does that stand for this group of patients?
Right. When I see especially biliary tract tumors, probably gallbladder and intrahepatic cholangio forms one category for me, and the rest of the biliary tract forms another category. Because when it is distal CBD, Klatskin's or periampullary, it becomes really difficult to target with radiotherapy, especially in an adjuvant setting. Post Whipples, we will definitely not be able to delineate the target in an adjuvant setting post Whipples, especially for the distal and Klatskin's and periampullary. When it comes to gallbladder and intrahepatic, definitely yes. We don't have any RCTs or trials substantiating the role of adjuvant radiotherapy, especially in an adjuvant setting, and which adds up to overall survival. But definitely yes, adding adjuvant radiotherapy has some local control, especially few of the retrospective series has shown benefit for those tumors which are T1B, especially if it is a T stage of more than 1B, and any nodal stage, be it N0 or N1, has shown some benefits of local control when we add adjuvant radiotherapy. And when we talk about advanced techniques like stereotactic body radiotherapy, then probably we have a first-hand experience of using SBRT, especially in intrahepatic cholangio and in gallbladder tumors. And we see that these tumors are easily targeted. And even in a palliative setting, when we add local treatment, especially in terms of RT or any sort of salvage surgery, it has shown some good local control, and it has added up to some progression-free survival. So in that way, probably SBRT plays a role in biliary tract tumors.
That's actually very, it's a good changing practice now, that adding SBRT to even advanced disease, getting some local control, getting improvement in DFS. I think in PFS, I think that's making a change in quite a lot of our practices. So I definitely think there is role of radiation in certain group of patients, and that's how we also look at it. But again, as we earlier discussed, we would definitely take that up in a tumor board kind of a discussion, or at least an informal discussion with all our colleagues. Right. Thank you for that. So let's, the last parts of it quickly. When you get an advanced metastatic disease as of now, what is the best first-line chemo do you use as of now, and what are you looking for further? Dr. Aparna, what are your thoughts on the first-line therapy now?
Sir, depends on the performance status, and if the PS is like 0 and 1, I would go for something like FOLFIRINOX, also the modified FOLFIRINOX. But if the PS is say 1 or 2, usually I stick to gemcitabine and either oxaliplatin or capecitabine, sir.
Okay. No, I was thinking metastatic setting, advanced disease, first line. This is your...
Yeah, metastatic. No, not metastatic, sir. No. FOLFIRINOX is for advanced disease adjuvant. When it is loco-regional, and maybe we want to convert it, borderline cases to convert it. But usually my standard is usually GEMOX.
Okay.
Yeah.
Right. And Dr. Naveen, advanced biliary to you, metastatic first line setting, what are you doing now, and what is your thoughts on moving forward?
I usually go for gemcitabine cisplatin, week 1 and week 8 for patients, and until now I have not started any patient on durvalumab gemcis, and we'll be thinking of starting it if there is no cost issues.
Right. So this is the data set which we are talking about a lot nowadays. Whenever we talk about the TOPAZ data, we've seen how the difference is between gemcis and gemcis durva. So the curves don't separate fast, and in the first 6 months we actually hardly see any separation of the curves, and we believe gemcis is working well, and it's after that where you start seeing the curve separation. Medians are just 1.5 months. Medians are really not too greatly different, but hazards are significant. And then you see the separation which happens. Dr. Vijit, you are impressed with this data, or you are not impressed? What do you think? Will you kind of follow this into practice?
So I have started using Durva gemcis, sir. In a couple of patients I have tried. I've started early days, so now a couple of cycles only. and before that I was doing Gemox. So I think only in one patient I've tried Nab-Pacli, Gemsys, and I think I burnt my fingers badly with that patient. So I don't think I'll be going back anytime soon to that combo in a young patient also. Probably Durva Gemsys is the way forward.
Right. I think the data wise, you are happy with this data, right? You're impressed with
Yes, I am, sir.
Right. So that's the thing that clearly there is a clear benefit, and the median doesn't look good. I think what impresses me is the 2-year data, and that's where we are happy with it. Otherwise, the medians were really not great. Till we just saw the medians, we were very kind of thinking there is some benefit. It's not a very great benefit, but I think when we start seeing 2-year survivals, 11% versus 23%, we're seeing clearly 12% patients more surviving at 2 years. We know we are hitting the flat of the curve is getting flattened, and that's what's important for us. So there will be a segment of patients who are going to do very well in the long run. Of course, we don't have ways to identify it, so that's the whole problem. Dr. Ravi, you are using Durva, Gemsys. What are your thoughts? Any group of patients do you prefer it to, or how do you choose to give it to your patients?
Yes, sir. We are using it on a regular basis because, as I discussed earlier, also the magnitude of benefit with chemo alone is very less, and giving second-line chemo is very difficult in this kind of malignancies. And here we are not looking at the OS, even a good PFS. Also, we are very happy. And it is well tolerated. I think with the Gemsys and cisplatin of split dose, it's a very good combination. And I think with past, we have used Gemox, Gemcapcitabine. Among all these options, even if the patient is not affordable for immunotherapy, Gemsys is the best option.
Right. So Gemsys is the standard chemo, but again, all of us have their own preferences, which we keep tweaking it because sometimes we think cisplatin may not be tolerated. But Gemsys has been the standard of care, no doubt about it. So we did see this year the data of the triplets. The phase 2 had given us the longest survival, and that's why we were very impressed with the phase 2 data. It's the phase 3 which came as a disappointment, but I still see the subgroups of the phase 3, and I clearly see the gallbladders with the triplets are doing better than the doublets. But again, the standard of care has changed. So now all new trials will have to be compared with Gemsys, Durva as the comparator arm. So again, we can't say where we stand with the triplets, but clearly for the intrahepatic triplets are not good. So I think we should stick to Gemsys as our baseline arm of chemo. Gemsys Durva, very impressive toxicity profile, not very toxic at all, and that's what's made all of us very happy in practice. Really, no major toxicities at all. We did see some data this time that patients who respond can have a very prolonged survival. And this is there with immuno, wherever immuno works. It's just that it doesn't work in many places, but if it works, it can work really very well. And so this is the impressive part of Gemsys Durva. Personally, what I was waiting for, I wanted to know subgroups where I could prefer it. So if a patient has an FGFR, if a patient has IDH1, will they respond so well to Gemsys Durva or will they not respond? Or if a HER2 will respond or not? We did see some data this year about that. Last year, we saw the detailed presentation, but it's still not very convincing to say that we can really rely on subgroups. So possibly no subgroups at all. We would probably give Gemsys Durva to everyone. And lastly, testing really does not matter. PD-L1 has shown no importance. So PD-L1 is not very important in our TOPAZ data set. So we really don't require a PD-L1 data. We can just give Gemsys Durva to everyone. I think so we saw the PFS benefit, we saw the response rates, we saw all that data sets, and I think all of us are quite happy with the Gemsys Durva data. Of course, if we can have something better, we want that. That's the way we are looking at. So final thoughts, I think I will take from Dr. Aparna, and what are your thoughts about this Gemsys Durva? Will we be using more and more, or will you be restricting it to certain populations? How are you thinking about it? If your patient has good performance and patients can afford it.
Yes, sir. I think immune checkpoint inhibitors are the way forward. And as we start using it and we get first-hand experience with different patients, I think we will be advocating it to more and more patients.
Right. I think so. I kind of agree with you. We'll just have to get more habituated to using it and getting that tail of the curve. Dr. Naveen, your final thoughts?
Yeah, if we can use it, I will definitely use it. But I have one question, sir. In UK ABC trial, the median overall survival was 13 months. In Topaz 1 trial with Durva, the survival was 13 months. In this one Imbreva trial also, the median survival is again going with around 13 months with atezolizumab, bevacizumab, and Gemcis. I'm still confused with though I can't compare different trials, but the median overall survivals with all the street trials is around 13 months.
Right. So that issue comes with cross-trial comparison, because
Yeah,
all
yeah.
trials will have different populations of biliary tract cancers. And what we don't hear is how much percentage were this, how much percentage this, and how did all of them fare. So very interestingly, to bring to your point, if you see the subgroup analysis from Topaz about intrahepatic, perihilar, and extrahepatic. So the survival of the intrahepatic was the longest, which we thought would be opposite. We always say our gallbladders do the best, extrahepatics do the best. They actually had the least survival. We saw the least benefit of Durva in those group of patients. But again, these are small populations. Coming back to your point, when we do cross-trial comparisons, we don't know these groups, how many are these, and they are all mixed together in one study. So that's why I feel the randomized data is the best way of knowing in that trial what the survival was. So to give your answer to the same way, the triplet in the phase 2 data set, actually triplets show it was a very impressive survival. We had a median OS of 19 months in the triplets. And that's the reason why I can tell you, I moved to triplets for my fit patients a few years. I think in the last couple of years, I've given so many patient triplets because the phase 2 said 19 months OS, which we had never seen in any gallbladder cancer. But then when you did a phase 3, it didn't turn out because again, populations are different and randomization happens. So what we are learning is whatever survival we get, we have a hazard of 0.8. So we are improving the survival when we add durvalumab. So probably instead of seeing only medians, we should see that by adding Durva, we are improving survival, at least in a certain group of patients. Only my hesitation becomes that improvement could have been, or what we want is always we want better and better improvement. And that's what sometimes we don't get. And that's why we become a little unhappy with the data set. But I think this is a clear positive trial, really not too much factors impending it, clearly showing all group of patients, adding Durva is improving whatever benefit you are getting with Gemcis.
Dr. Amit.
Yes.
Coming to the, again, as you told, Topaz subgroups, is it like a combination of chemo and Durva would have eliminated that PDL1 subgroups, the benefit, or did it negate the benefit? Is it something like that?
So it's a very tricky thing, Yeah. So if you look at the genesis of immunotherapy combination with chemo, look at all the old trials. If you look at even the data sets, wherever earlier we gave gemcitabine combination with chemo, we had the least benefit with immuno. So it was thought that gem is not a great partner for immuno. If you look at all the trials, when you use taxanes, you get a great benefit. When you use other carboplatin pemetrexate with immuno, you had great benefit. But if you look at all the lung data sets, when you use gem, you did not get a great benefit. So earlier it was thought that gem has a sort of immunosuppressive role. So when you give immunogem together, the benefit is not so great. This was what our earlier thought was. Till Topaz came out and till Poseidon came out. So if you look at even the Poseidon data in lung, you have one subgroup where you have gem given, there is a benefit. So you thought, no, it does work to some extent, not that great. Then we got the bladder data where we saw some benefit is there, even if you got gem there. But Topaz is one of the trials where gem has now shown that it does not matter. Even if you're adding immuno to gem, it works. And now we have the breast cancer, the triple negative Pembro data where you got Pembro plus chemo where gem was allowed and you got the same benefit. So now we are learning immuno plus gem is fairly good. It does not matter. The questions we ask are, what if I did a triplet plus immuno? Can I do that? Now, the thought is, theoretically, we may be doing great, but practically we may be giving so much chemo that the T cells will get wiped out. So there may not be enough T cells to get activated. So practically it may not be a good idea. But see, these are all theories we form about immuno, but we don't know the answer until they do a proper trial to see whether it comes positive or negative. So that's the reason why we say probably the best thing to do is Gemsys Durva. And yes, I know this is an Astra meeting, but recently we have heard the new release, the press release came out that Pembro is also positive for Pembro chemo in gallbladder cancer. So now we are going to have one more option which will come in. So news is I think in the next couple of months, we'll see that data set also. It's a press news which we have already that the positive study is out, but we don't have the numbers. So we don't know.
We also have IMBRAVE 151, Atizo with Bay with chemo.
No, but that is phase 2, So phase 2 for immuno, making a phase 2 change practice is very difficult. For immuno, you need a phase 3 data. I always believe for immuno, it's very difficult to accept a phase 2 data and start using it in practice. For immuno, especially. For chemo, it's sometimes easier, But for immuno, you need that phase 3 data. So we have now a phase 3 Pembro trial, which is positive, which has been now announced in the press meet. So we have that data which will come out. But I think the best thing is we have options for our patients. We have a lot of things we can do, and we have to think more and more for our patients. We can't leave our cholangio saying.
I have a very straightforward question. If you are considering a immuno-chemo combination, so then the PD-L1, the significance of the PD-L1 will go away. That is what we need to.
So as per Topaz, there is no significance of it. That's what Topaz showed us. Topaz showed. So again, you can criticize Topaz saying, why did they use the TAP score? Why didn't they do a classical? They could have done a CPS, and the CPS answers the same thing, but they changed the CPS and they made a TAP score, and you had to use the TAP score, and you don't know whether TAP score is showing the same information. But what we are learning is high PD-L1 benefit is more, low PD-L1 benefit is lesser, but the benefit is still there. So my thought is to you is, if you have a patient who is PD-L1 negative, will you not offer it? That's the difficulty. You will still offer it because the benefit is there. It's just that the benefit is lesser. So that's why PD-L1 becomes a very difficult marker to choose on.
Or I have a thought. They say cisplatin is an immunogenic. When you add a chemo, it makes tumor hot or more immunogenic, which is setting the stage for your immuno drug. Probably that is a rationale to combine chemo with immuno. That is a way to.
So theoretically, we are correct because we learned it from the lung, we learned it from the head and neck, and we made that theory. So we said theoretically, if you add chemo, you kill the cells, you will release new antigens. So new antigens will make T cells come in and you are activating the T cells. But my thought is this, if this theory works, it should work in every cancer. Why didn't it work in bladder cancer? Big trials you did in urinary bladder cancer. You couldn't say even a single trial where you combined them concurrent shared benefit. Only the sequential javelin worked. But a concurrent one came negative. So my thought is, it's not so straightforward. You don't know what is the quality of T cells. You don't know how immunosuppressive the environment is. Sometimes it is the environment itself. It is not only the T cell part or only the tumor PD-L1 part. And that's why, see, small cell, it is so immunogenic. You have high TMB, you have so many neo mutations, you have everything there. You have smoker population, which gives you everything. But you see the immuno benefit, it's a 1.5, 2 months benefit. I would have said there the benefit should have been the maximum, but you don't have benefit. So this is what it's not. So we can make theories and we kind of understand from theories a little bit more, but we can't rationalize it for patient usage. So eventually we then fall back to clinical trials and guidelines to follow what we will follow for our patients.
I know.
Right. So I think
you said randomized trials are the only way to answer these things, and that's how it works.
Absolutely. I cannot reiterate that fact, So we sometimes jump the gun, We see good phase 2 data and we think, oh, this is great. And then you do a good phase 3 balanced data and it doesn't come out positive. And especially I say in immuno, immuno is so, the way it works, the way you get responses, there will always be a segment which will do well, but it should be proven in a randomized phase 3 before we start using it in clinical practice.
I have only one hot burning question. If you have a platinum ineligible patients, then what you're actually going to do?
That is a very tricky point for clinical practice. So let me tell you what I do. I would still give a weekly chemo regime and I would still add the durvalumab. I would say, why not? You really don't believe that it's just the platinum which is doing it. It's just that, so in clinical practice, when we can't give platinum, we still give chemo. When we give sometimes nab-paclitaxel gem, we would give that. We would give gem with some other combination, which is perfectly fine. And I would say, though we don't have the addition of Durva data, I think it's going to work the same way. I don't think it's a specific drug which does it. It's the chemo, which is the combination which is helping.
No, most of the time we end up having that platinum ineligible patients, elderly patient with nephropathy, some kind of comorbidity, comorbidity patients, where we cannot even imagine any platinum. We end up seeing those patients.
No, I would say carbo is a good drug. I don't think there's any reason to deny patients saying we can't give weekly carbo instead of cis in patients who can't take cisplatin for any reason.
And as you rightly said, even GEM nab-pacli is also a good combination. What we are doing it for so many years.
Absolutely. And we have a phase 2 trial also, which was positive, but then the phase 3 didn't work out that well. That's the reason why everyone again kind of moved backwards. So I think all these regimes are good. But again, for clinical practice, as much as we can, we should stick to clinical trials data. But yes, we will have to adapt to our circumstances, and which we do, which all of us do every day in our patients. I think all of us adapt the maximum when
we're forced to do it.
Yes, absolutely. And that's the way we practice. And I think we are making a difference in survival of patients. There's absolutely no doubt about it. All of us have cholangios, gallbladders surviving years now. So that's why we are all saying what we do are doing correct. That's as long as we are in good intent doing it, we are doing correct.
Absolutely.
Right. So I think we've taken up a huge amount of time of your space today.
Thank you so much for that wonderful discussion. Thanks again. Thank you so much. We had a wonderful piece.
Thank everyone in the panelists for that excellent discussion. Thank you very much.
We never imagined biliary tract cancer sessions would be so long to discuss. So many things would line up to discuss, isn't it?
Absolutely. I think in the next 2-3 years, as Ravi mentioned, we will be doing so much more. All that availability of those drugs should come, those tablets come. The
one
idea
which you showed in the chart is amazing. So many mutations, plethora of mutations, and I think something similar to lung.
Absolutely. I think it's going to be a very impressive space, and there's really no doubt about it.
Yeah, I would agree. Thank you. Thank you so much, Dr. Amit, for a wonderful discussion. I thank all the panelists who made it this session wonderful and very interactive. I thank Dr. Aparna, Dr. Naveen, Dr. Vijay Kumar, Dr. Naveen Jairam Anvekar, Dr. Vijit, and Dr. Ravi Tippasamy. Thanks for joining us, and it was a wonderful interactive session. Thanks again to all the panelists. Thank you so much. So with that, we will end the panel discussion, and I would like to call upon Dr. Rajiv, my very good friend and consultant at BGS Global Bangalore. I would request him to present Napoli 3 data. Over to you, Rajiv.
Hi. Thank you, Dr. Srinivas, for inviting me for the meeting. Are my slides visible?
No, Rajiv, it's not visible. Technical team.
Okay, can someone help me with this?
Ishika?
Yes, sir, your slides is visible. Please make it a slideshow mode.
Yeah, Rajiv, now it's visible.
Yes. Is it now visible?
Slides. I'm doing it.
Hello, is it visible now? Can I start?
Yes, sir, you can.
Okay. Hi, good evening to one and all. Thank you to Dr. Srinivas for inviting me for this conference. I really enjoyed the panel discussion held by Dr. Amit Rotan. It was a very, very, very interesting panel. So what we're talking now about Napoli 3. It's a randomized open label phase 3 study of liposomal irinotecan plus 5-FU-leucovorin oxaliplatin. That's Folfox along with irinotecan, something akin to a folfirinox. But it's here that it is liposomal irinotecan versus nab-paclitaxel with gemcitabine in treatment-naive patients with metastatic pancreatic ductal adenocarcinoma. So for CA pancreas, whether you use gem nab-paclitaxel, which is a standard of care, versus you use something like a folfirinox, but using liposomal irinotecan. So pancreatic ductal carcinoma is an aggressive systemic disease with increasing incidence, and it's one of the most frequent cause of cancer-related death by the year 2030. So what is this drug? Liposomal irinotecan. This drug in combination with Folfox is approved in the USA, Europe, and Asia for adults with metastatic pancreatic ductal adenocarcinoma following progression with gem-based therapy. So phase 1 to 2 study demonstrated promising anti-tumor activity in patients with metastatic pancreatic ductal carcinoma who received it in the first line, that is liposomal irinotecan 50 milligrams along with the FOLFOX. Here the oxaliplatin instead of 85, it's 60 milligrams. So this is called NALIRIFOX. So now we're talking about the results from the phase 3 Napoli trial, which showed that it is both efficacious as well as it is safe enough when compared to gem-nab-paclitaxel. So the study design, so they had around 700 people, 770 people who were included in the study. So these people were confirmed pancreatic ductal adenocarcinomas. They were treatment naive. So the metastatic disease was to be diagnosed less than 6 weeks prior to the screening, and more than one or more metastatic lesions should have been measurable by CT or MRI as per RECIST 1.1. And of course, the PS or the ECOG status should have been 0 to 1. So they were randomized as 1:1. The NALIRIFOX, that is the trial group.
Rajiv, the slides are not moving.
Oh, it's moving for me.
Oh, it was not moving.
All right. The team, can you all help me out? I'm on the Napoli 3, the third slide right now.
It's in the second
Sir,
slide.
can I run from my side?
Yes, you please run it from your side. Okay, the next slide, please. Yes, please. Next slide, please. Okay. So here the previous slide, please. So we had the NALIRIFOX, which had 50 milligrams of liposomal irinotecan, along with oxaliplatin 60 instead of 85 when seen in FOLFOX, day 1 and 15 of a 28-day cycle, very akin to FOLFIRINOX. And then the other opposite was gem-nab-paclitaxel, day 2, day 1, day 15. And next slide. So these patients were treated until disease progression or unacceptable toxicity. So the endpoints were, the primary endpoint was overall survival. Secondary endpoints were PFS and overall response rate. The exploratory endpoints were quality of life and other biomarker assessments. So the study started off in February 2020 and ended by around July 2022. The overall median follow-up is around 16 months. Next, please. So the patient disposition, here we see that here the percentage of patients who discontinued the therapy around 85% in the NALIRIFOX and 96% in the gem-nab-paclitaxel. And the most common reason was disease progression, followed by any adverse events, and then followed by death. Next. Both of these, the baseline characteristics were well matched. We had here we see that people, most of them were ECOG 1, that is 58% were ECOG 1. People with both blacks and whites were chosen, and the number of people with more than 3 areas of metastases were almost around 40% in both arms. So we had a representation from North America as well as East Asia, and around 70% of them were from the rest of the world. The most in the pancreas, it is the body and tail of the pancreas which encompass most of the malignancies. The CA 19.9 was more than 37 in more than 80% of the patients. Next, please. Here we see the median overall survival in the intent to treat population. Here we see the median OS is around 11 months when compared to 9.2 months with the gem-nab-paclitaxel. So the hazard ratio of 0.383 was significant, and with a p-value of 0.04. Next, please. So now when we see the OS subgroup analysis, what do we see? Here we see that the places where we had the number of metastatic sites were only 1. There, it was whether you used NALIRIFOX or whether you used gem-nab-paclitaxel, it probably didn't matter much. Also, we see that if the baseline ECOG performance was not 0, there too, it is trending towards, although it's on the NALIRIFOX side, it is trending towards the gem-nab-paclitaxel side over there. Rest, even for people more than 65, contrary to our belief that gem-nab-pac is better, NALIRIFOX very surprisingly did much better in these patients. And people who had lesser CA 19.9, these people also NALIRIFOX was a better agent to go with. Next, please. So as per the median PFS, as per the investigator ITT population, here we see that the median PFS was 7.4 in the NALIRIFOX arm when compared to 5.6. Here the p-value becomes very significant with less than 0.0001. Next, please. The hazard ratio was 0.69. So when we see the PFS subgroup analysis over here too, we see that the more the number of metastatic sites, the better it is for the NALIRIFOX scores better over there. And again, here we see that if its ECOG status is 1 or more, then afterwards it is trending towards the GemNAPAC side. And here too, we see that surprisingly, more than 65 years, the patients more than 65 years, they actually did well with NALIRIFOX when compared to GemNAPAC. There was no difference between male and female in either of these. Next, please. So now the tumor response, we saw the OS, we saw the PFS, then in the investigator-initiated PFS as well. Now let's look at the tumor response. Here we see the complete response was seen, it's very similar in both the arms. Partial response was more in the NALIRIFOX, and when compared to GemNAPAC at around 41%, and progressive disease was more in the GemNAPAC, showcasing that there's slightly a better advantage when you use a triplet regimen like irinotecan, oxaliplatin, and 5-FU when compared to just a doublet of GemNAPAC, which is the standard of care as of now. Next, please. So now subsequent anti-cancer therapy. So we see that people who were on NALIRIFOX, they had around 50% of them underwent subsequent therapy, other anti-cancer therapy, whereas 54% in the GemNAPAC underwent subsequent therapy. The number of patients who underwent surgery was very dismal in both the arms, just around 0.3. That amounts to just around 2 to 3 patients in the whole trial, suggesting that both of these did not make the patient amenable to surgery. It is just only that we are looking at slight improvement in the OS and improvement in the PFS. Next, please. Well, when looking at the adverse effects, this is a very important entity because we tend to believe that giving a triplet is going to be more toxic. Here we see that in both the arms, the treatment associated adverse events was 99% in both. So the grade 3 was very similar, 87 in NALIRIFOX and 86 in GemNAPAC. Here, let me remind you all, here we are using Gem and nab-paclitaxel day 1, day 8, day 15 to 28 days. Most of us end up giving Gem-nab-pac day 1, day 8 to 21 days because to avoid the toxicity. But if given in the dose of day 1, day 8, day 15 to 28 days, it is as toxic as a triplet regimen. So the number of people, in fact, the number of percentage of death was more in the GemNAPAC arm when compared to the NALIRIFOX arm. Next, please. So now the treatment affects more than 10% of all the patients. Here we see that when irinotecan is used, naturally you're going to have a large amount of diarrhea and nausea, which is seen in the NALIRIFOX arm. So we see that again, vomiting also is more over here. The neutropenia, very funnily, is very similar, any grade as well as grade 3 and 4. In both of these arms, it is very, very similar. And in fact, in the GemNAPAC, your anemia is more. The neutropenias and febrile neutropenias are very, very similar in both the arms, whereas anemia is more. And as we would expect, thrombocytopenia is higher in the GemNAPAC because we all know that gemcitabine causes a lot of thrombocytopenia. It's higher in that in the control group when compared to the NALIRIFOX. Next, please. So in conclusion, in the phase 3 Napoli-3 trial, liposomal irinotecan in combination with 5-FU leucovorin demonstrated and oxaliplatin demonstrated a clinically meaningful and statistically significant improvement in the overall survival. That is a median OS of 11 months versus 9.2 months. It gave us almost around a 2.5 month benefit with a significant p-value, and the PFS benefit was 7.5 months versus 5.5 months with again very significant p-value of less than 0.001 compared with GemNab in the first line treatment of patients with metastatic pancreatic ductal adenocarcinomas. The OS and PFS benefits with NALIRIFOX versus GemNab were generally consistent regardless of the ECOG status, region, or the liver metastases. The safety profile of NALIRIFOX was manageable and consistent. Like we saw, apart from the nausea and the loose motions with irinotecan, they were all very comparable. Of course, we had a little bit more anemia in the GemNab pack arm, whereas the incidence of febrile neutropenia and neutropenia as overall, surprisingly, was very similar in both the arms. So the results, these results support that NALIRIFOX is a new regimen which we can use in a patient with a good PS, like Dr. Aparna was mentioning. Patients with good PS, she gives FOLFIRINOX for cholangiocarcinoma. Similarly here, NALIRIFOX, that is liposomal irinotecan along with FOLFOX, dose modified, is a new reference regimen for first-line treatments of patients with metastatic pancreatic ductal adenocarcinoma. Thank you.
Thank you, Rajiv, for that wonderful presentation. We are learning something new, though liposomal irinotecan is not available. Probably it should be available sooner in our country as well. Probably when it is available, as I rightly pointed out, when we use FOLFIRINOX, the toxicities, all those issues are there, but maybe relatively better. As you rightly said, day 1, day 8, day 15, day 28, that regime of Gem Platinum would be more toxic compared to your NALIRIFOX regime. Probably when it is available, I think this makes a good regime for a very suitable patients, and I think something encouraging for us to offer, isn't it?
Very true. Very.
What is your opinion?
I think it's a matter of time since we will start using this on a regular basis, and we would definitely have a very good response because all of us have been using FOLFIRINOX, and it's just a matter of time when it will become actually a standard of care. This as well, but again, liposomal, we don't know when it's going to come, so it is definitely something that we would need to see.
Absolutely, absolutely. Yeah. Thanks for that wonderful presentation. I call upon now Dr. Arvind, who is a radiation oncologist at CMC Vellore, a very good friend of mine. Dr. Arvind, are you there? He's going to present celiac plexus radiosurgery for pain management in advanced cancer, a phase 2 trial, and aspects of health-related quality of life. Dr. Arvind, over to you.
Sir, good evening. Good evening, Srinivas.
Hi, Dr. Arvind. How are you?
All good, sir. All good.
Thanks for joining us. Over to you.
Thank you for the opportunity. Not able to somehow share. Let me just try to share my screen.
Ishika or Gitika, we are able to see the slides actually.
Is it, sir? You're able to see the slides?
Yeah, I'm able to see the slide actually. But I'm not sure whether you can move it. Just move it and see. Yeah, it's moving. It's moving. It's moving.
Okay, sure.
Good to go.
Okay. Thank
Sir,
you.
from my side, I can run the slides.
Sure. No, if it's moving, I can do it myself. No problem.
Sir, this is my screen actually.
It's your screen. Okay, sure. Sure. Can you change then to the second slide? Yeah, thank you. So this is sorry, can you just go back to the first slide, please? Just a minute. I'll just, yeah. So this is a phase 2 trial, which was recently presented in ASCO GI conference in January 2023. So what they've presented as an abstract is the health-related quality of life outcomes of celiac plexus radiosurgery for pain management. Can you move on, please? So just to introduce, pain is a characteristic feature of pancreatic cancer right from the diagnosis to the terminal stage. And almost 1/3 of the patients usually present with moderate to severe pain at diagnosis itself. And why this pain is because of invasion of the celiac nerve plexus, which is the main reason. And apart from pancreatic cancer, other types of metastatic tumor deposits can also directly infiltrate the celiac axis and similarly cause this celiac plexus retroperitoneal pain syndrome. Can you move on, please? So the conventional pain management techniques include opioids, celiac plexus nerve blocks, which is an invasive technique, and of course, palliative chemotherapy with the regimen which was recently discussed. But with all these, there is minimal to moderate success rate, but with significant associated side effects. Next slide, please. So one of the ways of ameliorating or reducing the use of opioids is to try radiation. So palliative radiation thus far has been used with conventional or moderate hypofractionation, that is 30 gray in 10 fractions, with limited success. But to overcome the radiobiology, one of the ways is to give a very high dose in a very short time. So usually it's given as a stereotactic radiotherapy, that is within 5 fractions, or stereotactic radiosurgery when it's given in a single fraction. Next slide, please. So the key hypothesis that ablative radiation targeted to the celiac plexus will alleviate the pain, and this decreased pain will be associated with improved patient functionality, quality of life, and hope. And also it will be associated with decreased caregiver burden apart from just the patient benefit itself. Can you move on, please? So the primary endpoint in this trial was complete or partial pain response based upon this pain scale. It was 11-point pain scale, and a decrease between the score immediately before treatment and 3 weeks post-treatment of more than or equal to 2 was considered as a significant primary endpoint. And the secondary endpoints were change in the daily total opioid usage, especially morphine, and it was calculated in terms of the equivalent dose of morphine, and the number of times breakthrough analgesics were required. And the health-related quality of life, which was what was calculated in this particular presentation, was based on a FACT questionnaire. So it was a 45-point questionnaire. So patients who are more than 18 years with a malignancy that is either metastatic or unresectable, with severe retroperitoneal pain syndrome and anatomical involvement of the celiac plexus, and any pancreatic cancer, any other cancer that on imaging was involving the retroperitoneal space with the celiac plexus involvement, and any patients with prior chemo or biological treatment were also allowed, but the only condition was that there should not be any oncological intervention 6 days prior to and 6 days after the radiation. Next slide, please. And patients who were well balanced in terms of pain control with life expectancy of very short, significant comorbidities, and poor ECOG performance status with previous radiotherapy to upper abdomen were all excluded. Next slide, please. So this was the schema. So they aim to accrue cancer involvement of either the celiac nodes or the celiac plexus with severe lower abdominal or lower back pain with more than 5 on 10 on the BPI pain scale, and age more than 18 years. So after an informed consent, radiation planning and radiation treatment with an intensive follow-up for the first 6 weeks and long-term safety follow-up until death was what was done. Next slide, please. And how was it contoured? So the celiac plexus is tricky because it's not visible on our conventional CT, which we do for planning. So what they did was they used the vertebra, which is easily seen on the CT scan, and the aorta, which is seen in front of the vertebra. So they used the T12 to L2 vertebra as the surrogate, and they included the medial and anterior aspect of the aorta from these levels to call it the celiac plexus. And the tumor immediately adjacent to the celiac plexus was based on the physician's discretion. So if the physician decided to include, they could, and prescribed dose to such tumor was recorded. Next slide, please. So this is just a picture of what they included. So just to show that the aorta and in front of the anterior to the aorta and medial to the aorta was included from T12 to L2 level. That is what is shown in the picture. Next slide, please. So the prescription dose to the celiac plexus was 25 gray. However, one thing which we know is that GI, especially the duodenum, it lies in very close proximity to the celiac plexus, and it is very sensitive to radiation. So to overcome this challenge, they use something called a dose painting technique. So what is this dose painting? Next slide, please. So this dose painting is nothing but doing a dose within the dose within the dose. So it's like giving a lesser dose to area which is very close to the duodenum. That was called PTV 10, that is 10 gray. So the areas close to the duodenum used to get something around 10 to 12 gray with a deviation of less than or equal to 2 gray, whereas safer areas got a higher dose of 15 gray, and more safer areas got 20 gray, and the core, that is the area around the celiac plexus, got as high as 25 gray. So all this was given simultaneously in a single fraction. Next slide, please. And they had acceptable dose constraints for the kidney, the bowel, the liver, and the spinal cord, all of which are in close proximity in the abdomen. Next slide, please. And they had strict criteria for treatment delivery. It had to be on a megavoltage linear accelerator, and it had to be image guided with at least a cone beam CT. And as I mentioned, the criteria was that there should not be any systemic or biological therapy 6 days prior to and 6 days after treatment. However, there was no restriction on usage of analgesics, and all patients received prophylactic antiemetic medications such as palnositron, dexamethasone, and proton pump inhibitor. Next slide, please. So coming to the results, so 149 patients were consented to treatment. However, 125 only could receive treatment, and finally 90 were evaluable for analysis. So most of them were predominantly women and white, almost 94%, because of course this was done in Israel. And the mean age of the patient was 65 years. Primarily, it was a pancreatic tumor with 86% of the patients being metastatic. And most of them were good performance score patients, with most of them being ECOG 1. And they all had received at least one line of systemic therapy on average, ranging from 0 to 5, and a pain score at baseline of at least 6, and opioid use of at least 54 mg of morphine equivalent per day. Next slide, please. So of the primary endpoints of the 90 evaluable patients at 3 weeks, so 48 encouragingly had a good response, that is almost 53.3%. And whether the decrease in the pain score was more than 40% was significant. P-value was 0.013. And this graph is showing use of short-acting analgesics per day. As you see, it gradually decreased over 3 and 6 weeks. Next slide, please. And also health-related quality of life. It was evaluated on the FACT HELP questionnaire across 45 points. And most of them showed significant p-value of less than 0.05, especially when you see 3 weeks and 6 weeks. So from 3 weeks to 6 weeks, there was good improvement compared to pre-treatment. Next slide, please. Apart from the main pain score, there was also an improvement in, if you can see, the physical well-being, the emotional well-being, social and family well-being, and also functional well-being immediately after treatment, that is 3 weeks post-treatment, and also at 6 weeks post-treatment. And the p-value, whatever is in asterisks, was significant. That is 3 and 6 weeks in physical well-being, 6 weeks at emotional well-being, and also from pre-treatment to 6 weeks in the social and family well-being. Next slide, please. So to conclude, this was a short phase 2 trial where celiac plexus stereotactic radiosurgery decreased pain, opioid use, and pain interference scores with minimal side effects, providing a new possible treatment option for pancreatic cancer pain and other tumors invading the celiac axis. Of course, it is in addition to all the other treatments which are already available, like chemotherapy, immunotherapy, and analgesics. Thank you. Happy to take any questions, if anything.
Thanks, Arvind, for that wonderful presentation. I have a question. So yes. Many of the times we end up doing celiac plexus block or some kind of rather palliation in many of our patients. So do you think is stereotactic surgery to celiac plexus would be a surrogate or would be an alternative to these patients? Because a lot of times we don't have facility to do a celiac plexus block in many of the hospitals.
Correct. Yes,
so is it a good way of looking at a radiation intervention in these things?
Yes, I think as of today, most of the cancer centers have LINACs with at least a cone beam CT. Right. So any LINAC with a cone beam CT is good enough to deliver this SBRT. Right. And since we are delivering using bone as a surrogate marker, bone and the iota as a surrogate marker, we don't expect much motion also. So it should be easy to deliver even in, centers with lesser experience. Although we probably wouldn't be brave to give 25 gray in one fraction, even, give lesser dose per fraction, but give over 3 to 4 fractions when celiac plexus block might not be accessible.
Yes.
It's always,
Also,
it's always a
again, the
compliment.
celiac plexus block is also a blind technique.
Correct.
See, celiac plexus block, even anesthetist or a gastro intervention
Yes.
guy would do. It's also a blind technique. So
Correct.
most of the time we have seen the failures. Even after the celiac plexus block, the patient comes with still pain. He didn't get
Yes.
any relief. So I think probably this may be a more precision technique because you
Yes.
have a surrogate like a T12, L2 or iota or something like that, at least imaging guided. So that this is maybe better than that blinded technique, I feel.
Correct. So yes, so that's what from our experience, usually we start with a slightly lesser dose per fraction. So we usually give like anywhere between 8 gray per fraction to 10 gray per fraction. Start with that. And as we get more experience, I'm sure we'll be able to do it.
It will evolve. I think more and more practice,
Yes.
it comes, you'll be more familiar with the techniques.
Correct.
And those.
Yes.
Thank you so much, Arvind,
Thank you,
for that wonderful presentation. I think we have come to the end of these sessions. Thank you, each and everyone, all the speakers, delegates, audience, for making this meeting wonderful. It was past 3.5 hours. How it went, I don't know. The sessions were so wonderful. Each speakers had put their effort to a maximum to present this in a wonderful way. I thank each and everyone, and I want to thank all the sponsors, pharma people like AstraZeneca, Roche, Zydus, Glenmark, Merck, Bayer, Roche, Natco, Zydus, Intas, AstraZeneca, and Roche. All these, I want to thank all of them for making this meeting very successful and wonderful. Thank you, each and everyone. And I thank Ekta ji, Tarun ji, and their team, Ishika and Gitika. All these, every day we are in WhatsApp, we chat, we try to organize each and everyone. Wonderful guys, the technical team, they have done a wonderful job to make this meeting very productive and useful and wonderful. I thank each and everyone. Thank you, Ekta ji, for making this meeting very successful. Thank you, each and everyone, and good night. We have a day 2 session tomorrow at the same time, 5:30. I would like to invite all the speakers and present it in time so that we'll finish it off fast on Saturday and we close it up. Thank you, each and everyone. Thanks a lot. Good night.
Thank you so much, sir.
Thank you.
And good night.